Morning, everyone, and welcome. Thank you for taking the time away from your patients, rounds, families to be here for something that reaches beyond medicine, something deeply human. In our work in perinatal medicine, we celebrate beginnings, the tiny heartbeats and the first breaths. But sometimes those beginnings are shadowed by pain we cannot measure, intimate partner violence. Each year, far too many mothers carry the fear and trauma through pregnancy. These consequences are not only emotional, they are biological. And we see that. We see that showing up as preterm labor, fetal growth restriction, placental stress, and challenges in bonding. Often, you are the first ones to notice. As a nurse who senses the hesitation, as a resident who looks at the bruises, as a physician, as a psychologist, as a social worker, you are the ones who notice this first. And today's discussion is going to be more than protocols. It is going to be our shared role as healers, protecting both the mother and the baby in body and spirit. It's about the learning to see what's unseen and to hear what's unspoken. So as we begin, please remember, every mother who enters our care carries a story. And sometimes saving two lives begins with one brave question. And before we begin today's conversation, I invite all of us to pause, to take what I'd call, a collective breath together. And let's center ourselves on a shared space of learning, compassion, and purpose. And the way we're going to do it is with a brief exercise. And so if I have your permission today, let's take a short grounding moment, just a few breaths to reset. Now sit comfortably wherever you are. And if you want to lower your gaze or close your eyes or soften your focus, please do that. Now, inhale slowly through your nose. And I'm going to count up till 4. So inhale slowly through your nose. And on my cue, inhale for 4 seconds. 1, 2, 3, 4. Hold your breath for 4 seconds. 1, 2, 3, 4. Exhale for 4 seconds. 1, 2, 3, 4. You have to do this again. And at this point, you're only going to hear me say 1, 2, 3, and 4. And you can inhale, hold your breath for 4 seconds, exhale, and then hold your breath again. Let's do this exercise one more time, okay? And then we can return back to our natural mode of breathing. Okay, if everyone's ready, let's do this. Inhale, 1, 2, 3, 4. Hold your breath. 1, 2, 3, 4. Exhale. 1, 2, 3, 4. Now hold your breath and stay calm for the next few seconds before you return to your natural pace of breathing. Well, you can open your eyes now if you've kept them closed for a while. And let us move through this morning with open minds, grounded hearts, just like the exercise that we did right now, and our shared intention to bring light where there has been harm and hope where there has been silence. I'm extremely honored to welcome Patricia Cherry, our program manager for CMQCC, to review a few important points and introduce our first speaker. And thank you for giving me the opportunity to be here today with all of you doing such wonderful work. Thank you very much and welcome once again.
Thank you, Dr. Rao. Good morning and hello, everyone, and welcome to today's conference. Before we begin, I'd like to take a moment and recognize that this webinar is hosted by Mid-Coastal California Perinatal Outreach Program, originally developed in 1970s by the state of California with Title V funding, and locally by neonatologist Philip Sunshine and nurse leader Seal Acquaintance. The collaborative is an effort out of Stanford Medicine, including the School of Medicine and Stanford Medicine Children's Health. MCCPOP is led by team members of California's Perinatal Quality Collaborative, CPQCC and CMQCC. I'd also like to take this moment to acknowledge that Stanford sits on the ancestral land of the Muwekma Ohlone tribe. This land was and continues to be of great importance to the Ohlone people. Consistent with our values of community and inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationships to Native peoples. We honor their stewardship of this land, past, present, and future. And we commit ourselves to continuing this work in the spirit of respect, healing, and partnership. Now, CME accreditation statement. Stanford Medicine is jointly accredited by the ACCME, ACPE, and ANCC to provide continuing education for the entire healthcare team. This live activity offers up to 2.75 continuing education credits across multiple disciplines. Physicians, nurses, registered nurses, social workers. Participants should claim credit only for the portion of the activity in which they participate. Now I will provide an overview of the agenda. Today's program brings together researchers, clinicians, and advocates who are shaping the future of perinatal health and safety, especially for those affected by intimate partner violence. Dr. Chyna Hill will be setting the stage on background data and lived experiences. Dr. Maya Ragavan will talk about the latest research and the critical role of providers. We will take a 10-minute break, and then we will have Erica Villa spotlight on the Next Door program. And then we'll have a joint discussion with Dr. Chyna Hill and Erica Villa advocating for IPPV populations. And then we have Dr. Anastasia Coutinho, DHCS's coverage and support for screening. And then close to the end of the day, we'll have a panel discussion and Q&A. And then the MCCPOP team will do some closing reflection. Your participation makes this space vibrant, so please engage with our speakers during the Q&A, share insights, and help us continue building a network of action and compassion. Now, with no further ado, it is my pleasure to introduce our phenomenal panel of speakers. We have Dr. Chyna Hill, who is a PhD, LCSW and PMH-C, She is a licensed clinical social worker specializing in perinatal mental health, trauma-informed care, and culturally affirming practices. As co-founder of the Black Girls Mental Health Foundation, she brings over a decade of leadership, research, and advocacy dedicated to advancing equity for Black women and families. Then next we have Dr. Maya Ragavan as a pediatrician, advocate, and researcher at the University of Pittsburgh. Her work, funded by NIH, PCORI, and the Office of Violence Against Women, focuses on supporting perinatal IPV survivors, engaging caregivers in fostering healthy relationships, and promoting language in healthcare and research. And now we also have Erica Villa, Associate Director of Community Partnerships at Next Door Solutions to Domestic Violence, has advanced the agency's work since 2013 at the intersection of domestic violence, health, and community prevention. She has led major initiatives such as the DV and Healthcare Partnership Toolkit, and continues to build strategic partnerships that strengthen prevention and promote equity for survivors and their families. And then we also have Dr. Anastasia Coutinho, is a trained family physician and serves as a medical consultant at the California Department of Healthcare Services. In her role, she serves as a clinical consultant to a number of birthing care projects, hoping to improve the care provided to pregnant and postpartum individuals throughout California. And I will now pass it over to Dr. Chyna Hill. Thank you all.
Thank you, Patricia. That was truly lovely. Good morning and good afternoon, everyone. My name is Dr. Hill, and I am thrilled to be here with you all today to talk about nurturing safety in the perinatal period. And so we're going to begin with just a bit about myself. If we could move to the next slide. So I want to share a bit about how I arrived at this work. My first big girl job, as I like to call it, was at a small domestic and sexual violence center in rural Florida. At the time, I worked under a director who to this day remains the fiercest advocate and defender of survivors I've ever met. It was that experience and her mentorship that truly shaped everything I've done since. And although my work or my journey into this field started over a decade ago, I vividly remember spending my days sitting with survivors, hearing their stories, and leading conversations about healthy relationships with young people, hoping that I could make things better for the next generation. And it was at that time and through that work that I really started to realize something profound, that when it comes to what we do, every single role, especially as it relates to intimate partner violence, truly matters. So that means whether we're mentoring an intern, we're working within another organization, we're standing beside volunteers at a community event, each of us is already shaping what safety and care look like. That understanding has guided every step of my career and continues to shape the work that I do today. So with that being said, we're going to go ahead and jump in. So I want to take a moment to really ground ourselves in a shared understanding of what we mean when we say perinatal intimate partner violence. When we talk about intimate partner violence, often many people think of physical harm, but in perinatal care, it often shows up in much quieter ways. This can look like controlling finances, monitoring phones, sabotaging contraception, or isolating someone from their support system. What makes this period so critical is that pregnancy and postpartum are they're times of profound physical and emotional vulnerability, and the stakes extend far beyond just the individual. So for clinicians, for advocates, and systems alike, this definition really reminds us that safety is holistic and it has to include economic, emotional, and bodily autonomy. So at first glance, the number 5.4% may not appear very large. But when you think about how many births occur each year in the United States, this really translates to tens of thousands of women and birthing people navigating both pregnancy and violence at the same time. What's really important to understand is that this 5.4% just represents an average. When we look at certain populations, especially those served in public health clinics, community hospitals, or programs that support families experiencing poverty or housing instability, the prevalence rises dramatically. And these are often referred to as high risk perinatal or postpartum populations. But that label doesn't describe something inherent about the people experiencing IPV themselves. What it reflects is structural and social risk factors like racism, poverty, lack of safety nets, and chronic stress. So, in these contexts, IPV can range from 1 in 4 to as high as 2 in 3 participants or survivors, depending on the setting and how screening is done. And then when we take a look at the second chart on the right, it isn't comparing different ethnicities or geographic regions. It's really showing the range of findings across different types of clinical settings and patient populations. What I really want the takeaway here to be is that IPV is not a rare occurrence. It's a common and preventable maternal health issue that surfaces more frequently in the communities already facing the steepest barriers to care. And just as these numbers rise in certain settings, they also deepen along lines of race, language, and access. So we're going to take a deeper look at what that looks like in California. So when we look at IPV during pregnancy, which is what the Maternal and Infant Health Assessment tracks, 5.2% of birthing people statewide report being hurt by a partner. These disparities are even more pronounced among folks of color, which you can see the rates are higher than the statewide average. It's also really important to note that this could be a significant undercount of the full spectrum of partner violence, including emotional, sexual, financial abuse, and a lot of this is because of lack of disclosure. Even with these particular limitations, it's really important to just highlight that the data really reveals a pattern that we see nationally, and it's that inequity magnifies risk. So the MIH data that we just saw gave us an important window into the issue, but only part of the picture. But for many birthing people, violence starts long before any physical act. It can look like being monitored through your phone, being pressured around contraception, or having financial access cut off once pregnancy begins. These are forms of harm that don't always show up in data sets, but they show up in clinics, they show up in therapy sessions, and community programs every single day. So as we move forward, it's really critical to remember that the absence of data doesn't mean the absence of harm. It often just means the absence of systems designed to see it. So to truly understand what those invisible forms of harm look like and how they shape access to care, it's critical to really listen to the lived experiences of survivors. So when we disaggregate the data, clear patterns emerge. Black birthing people experience perinatal IPV at over twice the rate of their white peers. And in California, homicide linked to IPV is the leading cause of pregnancy-associated death. For the Latinx families, particularly Spanish preferred speakers, the challenge isn't prevalence alone, it's detection. Screening and disclosure rates drop sharply when language services are not present. And for Indigenous communities, data gaps themselves are part of the harm. While lifetime IPV rates are high and they're the highest among any group when it comes to Indigenous populations, perinatal screenings often fail to capture these experiences. And so the message here is that there isn't a difference in resilience, but there is a difference in access, there's a difference in recognition, and there's a difference in response. So while racial, ethnic inequities are well documented, other populations also experience unique barriers to safety and care. LGBTQ plus parents face outing threats and minority stress that really heighten IPV risks. Adolescents are also subject to power imbalances and school disruptions that make both prevention and disclosure difficult. For immigrants, fear of deportation or language barriers can completely shut down reporting. And in rural areas, the issue isn't just stigma, it's sparse services and access to firearms. And for people living with disabilities, dependency on caregivers can really blur the line between do I need support or does control. These populations remind us that equity-informed intimate partner violence responses must really account for intersectionality, not just a single identity. Next slide. IPV is never about a single factor. It's the result of conditions that build over time across multiple levels. So at the individual level, we might see histories of trauma, unintended pregnancy, or substance use that intersect with stress. Within relationships, patterns of control, jealousy, or financial strain can escalate risk. At the community level, poverty, housing instability, or exposure to neighborhood violence can create constant stress. And when we look at the societal level, we see racism, we see gender equality, and restrictive policies that further compound that risk. So, understanding IPV through this lens really helps us move from blame to context and from context to prevention. So, when survivors hesitate to disclose violence, it is not because they're unwilling. It's often because the systems around them haven't been safe places to tell the truth. For Black and Indigenous folks in particular, that mistrust is rooted in lived and inherited experiences. This ranges from forced sterilization and reproductive experimentation to current and contemporary examples of dismissal of pain and consent. Healthcare has too often been a source of harm rather than healing. And survivors also fear what disclosure might trigger. This could be CPS involvement, family separation, or being labeled as non-compliant. And these are not irrational fears. They historically have been protective factors to historical and ongoing trauma. So when we talk about building trust, we have to recognize that trust is not a prerequisite, right? It's something that must be earned through acknowledgement, through transparency, and through repair. And even when survivors do reach the point of trusting the healthcare system, bias in screening and responses often determine whether that disclosure leads to help or if it leads to harm. So when we talk about bias, bias can determine whether we ever learn if violence is impacting our families. Research shows that some providers are less likely to screen Black, Latinx, and immigrant survivors of intimate partner violence, even when other risk factors might be present. And even when screening does happen, it's often done under pressure. So, not enough time, no privacy, no follow up, and sometimes no interpreter. For someone who may already be in survival mode, that can feel more like surveillance rather than support. So, when it comes to screening, the issue isn't just if we screen, it also matters how we screen and whether the process reinforces the very inequities that we're trying to address. And, sometimes providers do every single thing right. Screening is done with care. So providers are practicing cultural humility. However, there are still barriers that go far beyond the exam room. So we're going to take a look at some of the structural realities that make safety and access so difficult to sustain. So think about what it takes for a birthing person to get to an appointment: transportation, childcare, time off work. All of these things may be out of reach for some of the families that we work with every day, especially for those who are living at or below the poverty line. In many states, postpartum coverage ends after just 6 weeks, and studies show that this is the point when intimate violence is the highest. It typically peaks. And you add that on top of lack of paid leave, lack of paternity leave, the cost of therapy. We know to see a therapist every other week for a year can cost as high as $4,000 a year. There's the fear of losing income. There's the fear of housing instability. And we've also created conditions where survivors are often forced to choose between safety and their survival. And then our systems, we don't talk enough to each other. So there's healthcare, there's social services, there's legal support, there's community organizations, and oftentimes, although intentional, we work in silos. And what this means for survivors is that referrals get lost, follow-up is inconsistent, and sometimes survivors are re-traumatized because they have to retell their stories over and over again every time they have to re-enter our entry system for the first time. And these aren't isolated failures or unique to California. These represent structural design flaws. But because they're flaws, that also means that systems and processes can be redesigned. So it is a combination of structural barriers that make violence not just a personal issue, but a major public health concern. So when survivors aren't seen or supported, the cost isn't only emotional. And that is measurable across every maternal health indicator that we track. So we know that prenatal and postpartum care might get delayed or missed altogether. We know that survivors are more likely to skip appointments because they fear disclosure, retaliation, or judgment. And that's what non-compliance is often a symptom of trauma, not disinterest in care. Second, the research also tells us that depression and anxiety rates of PTSD increase dramatically. The CDC indicates that intimate partner violence is one of the strongest predictors of perinatal depression and suicidality. In fact, mental health related causes represent the leading category of preventable maternal deaths in the United States. And third, the risk of preterm birth, low birth weight, and perinatal loss all rise. The biological stress pathways triggered by chronic trauma, we have elevated cortisol, we have sleep disruption, we have inflammatory responses. All of those directly impact mom's health, the birthing person's health, and fetal health. And finally, we can't omit one of the most devastating outcomes, and that's intimate partner violence related homicide. That remains a leading yet preventable cause of maternal death in this country. And these are not isolated incidents, they really are reflective of system failures all around the country. Every missed opportunity to identify and support a survivor deepens generational harm. And it's not just one person we fail. We fail their children, we fail their families, and the trust in our systems that we were meant to uphold. So, for many survivors, pregnancy is not a time of joy, it's a time of increased danger. The stories that you see depicted on the screen come from community work at Black Girls Mental Health Foundation, but have been re-emphasized in other qualitative studies. These quotes really remind us that safety isn't found in just healthcare settings, right? Sometimes it's the very place survivors learn to stay silent. You know, one mother told us that her partner was at every perinatal appointment with her, so she didn't feel comfortable disclosing what was going on at home. Another mom shared that she was afraid if she shared what was happening at home, her kids would be taken away. Because as mandated reporters, sometimes folks have to contact Child Protective Services, and it often ends up in mom being punished for seeking support. But these really are the real consequences of mistrust, of bias, and they help us understand while data points alone will never tell the full story. And then in general, across the literature, there are hundreds of interviews and focus groups, and these themes surface over and over again. Survivors fear being criminalized instead of supported. They describe doctors who changed the subject when they tried to disclose. Many shared that, community doulas, peer mentors, and culturally attuned programs really made the difference, and they finally felt safe enough to start the healing journey. What this tells us is safety really begins when survivors feel seen, when they feel believed, when they feel supported, and they don't feel managed. Survivors have also shared that healing doesn't start with just a referral. It starts with the relationship. So when we say trauma-informed care, we aren't just referring to a checklist. It's really a stance of curiosity, of respect, and cultural humility. And every interaction that we have, whether that's in an exam room or a therapy session or a community program, it's an opportunity to restore dignity. Collaboration should be key to what we do. When healthcare and community organizations work together, survivors don't have to navigate safety alone, and ultimately, trust really becomes the treatment. So, when we talk about IPV as a major public health concern, this is why. It's not just psychological, trauma literally changes the body's chemistry. Chronic stress during pregnancy increases cortisol, inflammation, and affects how the placenta protects the baby. That's why we see higher rates of preterm birth, low birth weight, and difficulties in emotional regulation. And the toll on maternal health is truly profound. Women experiencing IPV during pregnancy face up to twice the risk for preeclampsia and preterm birth, and they're nearly 70% at higher risk of mortality. These numbers aren't just abstract, they really represent the compounded effects of stress, injury, and fear in the body over time. And then trauma during pregnancy impacts more than just mom or the birthing person. It shapes how a child's stress system develops. So we know that elevated cortisol in utero changes how babies regulate emotion and stress in later life. That's why, I don't know if you all have ever heard the quote, but that's why we say babies feel what their mothers survived. We also now have evidence that trauma can leave molecular footprints in the DNA. So, genes involved in stress regulation actually look different in babies whose mothers experience IPV during pregnancy. This is the direct result of intergenerational trauma, but also the biology of resilience when healing begins early. So, screening is an important life-saving intervention, but unfortunately, it's not universally applied. Although 1 in 4 pregnant people may experience IPV, fewer than 40% are ever screened during prenatal care. So when we start to disaggregate data by race, by language, the picture worsens. Black, Latinx, and immigrant birthing people are screened half as often as their white counterparts. And there's a lot of reasons for that. And even among those who are screened, the process often ends after delivery. And that is typically when risk of intimate partner violence peaks. So the question isn't a matter of whether we believe in screening, it's who we're choosing to ask and who we're leaving unseen. So evidence-based screening is not just about using the right form or tool, it's also about creating the right environment. Survivors have told us what really matters most, and that's privacy, that's tone, that's trust. And when we open conversations by saying, we ask all of our patients about relationships because they impact health, we really normalize the question and we're able to reduce stigma. And screening isn't something that should be done once, it should be repeated during pregnancy, during postpartum, because the window of safety often changes. And if a patient does disclose, we shouldn't just hand them a pamphlet. We connect them to a real person. Ideally, this is a community advocate, a community partner, a community-based organization who can help walk them through next steps. So I want to introduce the cues model. I'm not going to spend a lot of time on it because one of my colleagues is going to give us a deeper dive here. But the cues model was created by Futures Without Violence, and it really was to move away from screening that felt like an interrogation. Instead, we wanted to push folks and everyone towards a universal education model. So it's built on trauma-informed, culturally responsive principles. These are especially critical when working with Black and BIPOC birthing people because these are folks who may not feel safe in traditional healthcare settings. And instead of only asking, are you being hurt? everyone is educated about healthy relationships, the available resources, and the CUES model really makes an effort to normalize support and what support can look like. And even if a survivor doesn't choose to disclose that day, they can at least leave knowing where to go and that their particular provider is safe. The CUES model really is a model of trust building, not surveillance, and that's why it's been so effective. So CUES really works best in systems that are ready to hold it. When we say a culture of safety, it means the front desk, the providers, the community partners, all of those folks have really been trained on trauma-informed, culturally responsive practices. This includes referral pathways, embedding advocates, evaluating success. And when we evaluate success, we don't want to just look at a number, right? We really want to understand qualitatively if survivors felt safe, if they felt supported, not just whether a screening box was checked. And each interaction can either reopen or repair trust. And that really is the difference between compliance and compassion. And trauma-informed care is often treated like a checklist, but it isn't just a protocol, right? In perinatal settings, this means slowing down to explain what's happening, right? Asking permission before touch, and letting survivors define what safety looks like for them. When we use the word cultural humility, what we're saying is cultural humility really transforms trauma-informed care from a checklist to a relationship. And when survivors, particularly Black and Brown birthing people, encounter care that is transparent, that is collaborative, that is respectful, that moment itself becomes healing. So when we embed mental health into prenatal care, rather than making this a separate referral process, we're able to see better outcomes because we have stronger teams, we have more supportive care, we have more collaboration, and we get better follow through. And models that really combine teams show huge improvement in engagement and postpartum recovery. But the key isn't just integration, it's also making sure that you have representation. So when it comes to thinking about what we've talked about today, if there is one thing I hope that I'm able to leave you with, is that intimate partner violence isn't an isolated issue. It's woven into every layer of health equity and maternal well-being. And our responsibilities, whether we are advocates, clinicians, medical doctors, isn't just to screen, but to create safety. And when we practice trauma-informed, culturally grounded care, when we follow models like the CUES model and we work alongside community partners, we don't just prevent harms, we are truly building and rebuilding healing systems. So every interaction, every question, every referral can truly be an act of restoration and a lifeline for our survivors. And so with that, I have just included some local resources as well as some nationals for survivors of intimate partner violence. Um, Thank you all for listening, following along. Really appreciate you. So with that, I am going to pass this over to my colleague, Dr. Maya. And I want to put a plug in here. Towards the end of the day, I will be having a conversation with my colleague, Erica Villa, about intimate partner violence and the different ways that we can show up for survivors of intimate partner violence, and hope you'll join us.
Great. Thank you so much, Dr. Hill. That was a fabulous presentation. I learned a lot. I'm really grateful to be able to share this space with you and our other colleagues, and also just be here to talk more about this topic that we care so deeply about. So I think my talk is a great complement to what Dr. Hill just shared, and I'm going to be talking a little bit about supporting perinatal IPV survivors in healthcare settings. Next slide, please. I just want to acknowledge many people that with whom I work, particularly all of the survivors and advocates who've shared their stories through my research, all of the medical students with whom I work, my research coordinators, my colleagues, and community partners as well. Next slide, please. And I just want to disclose that I do receive funding from a few different federal agencies. Next slide. Okay, so I know Dr. Hill talked about this, but just as a reminder throughout this entire morning, that really important to just take care of yourself. There are many folks among us who've experienced IPV, or you may have a friend or family or loved one who has experienced IPV. So, please take care of yourself. Turn your speaker off if you need to, step away if you need to, just whatever you need to do to take care of yourself during this talk. Next slide, please. And I also wanted to share resources at the beginning of the talk as well as at the end. So the first is the National Domestic Violence Hotline, and then I have the Next Door Solutions to Domestic Violence Hotline as well, which is a local agency, and we'll be hearing from an amazing IPV advocate from Next Door in a little bit. Next slide, please. So I'm going to be talking a little bit about how coercion can occur during the perinatal period, ways to support IPV survivors, making the shift from mandated reporting to mandated supporting, aligned with what Dr. Hill had been speaking about. And then I also just thought it would be a nice opportunity to share with you all a study that I'm working on around training doulas in supporting IPV survivors. If we have time, I'll share that at the end. So I want to start by just considering the story. So you're in a postpartum unit, you walk into the room, the birthing parent there tells you they're having trouble with lactation. They would like assistance from a lactation consultant, and they're worried their infant isn't gaining weight well. So you're looking, baby's full term, 48 hours old, only down 4% from birth weight, has been stooling, voiding well. So, I was like, oh, this was a true story. And I was like, oh, great, I can be reassuring and just, it looks like weight gain is okay and all that. And then you start to support the parent with lactation assistance, and a visitor in the room says, please tell her that she should formula feed. I don't think she has enough milk and she won't be able to breastfeed. The birthing parent's partner then agrees and says, I don't really think she knows how to breastfeed. So this is a real story. And I think when things like this happen, it can catch us off guard, right? And there's so much more context you all probably want to hear around this story. I think the way I framed it, it obviously doesn't sound supportive, but you could imagine a situation, well maybe this birthing parent has been really worried about lactation and is just really scared to even, that she's a bad parent, they're a bad parent if they don't, so there's so many different ways to think about this. And this is a real story. And this person was experiencing intimate partner violence. And this was the way that I was sort of clued into it, just seeing this sort of interaction that made me wonder about whether coercion was happening. So I just wanted to share that story, and then I'm going to be talking about ways to support folks and learn a little bit more about what's going on throughout the course of this talk. Next slide, please. So I won't talk a lot about this, but we know, Dr. Hill shared that IPV is rooted in power and control, and every survivor's story is different. The way that IPV shows up for them is different. This is the power and control wheel that looks at different types of power and control that can show up. I think one thing that's really important in the perinatal period is using children. I should have said I'm a general pediatrician, and I have seen time and time again the way that people who use violence use children to coerce and control IPV survivors. And so I think that's just something we need to be very aware of. Next slide, please. But there are other ways other than what I just shared, how power and control can show up. So for a couple minutes now, I do want to talk a little bit about some of the research that my team has worked on to look at how power and control can show up in pediatric settings and perinatal settings. So this was a study we did where we interviewed pediatric IPV experts around how they've seen power and control show up in pediatric settings. And I know not all of you are pediatricians, but I think many ways the perinatal period is also a pediatric setting. And they talked about lots of things. They talked about withholding transportation so somebody couldn't come to a well child visit, using the healthcare system to stalk, which I think is particularly important in the context of patient portals where people a person who uses violence may have access to a child's medical record and therefore may be able to know when the child has a medical visit. Trying to align with providers or discredit the survivor. So you saw that happen in the story that I shared, not allowing the parent to speak during visits, trying to control medical decision making. So I remember a story once where a parent who was experiencing coercion in their relationship really wanted to vaccinate their child, and their partner was refusing that and was sort of demeaning the other parent's opinion about vaccines. or trying to manipulate appointments. And so these are several examples of how power and control can show up in healthcare settings and just things for us to be on the lookout for. Next slide, please. And then during the pandemic, we saw ways that COVID-19 was used to exert power and control. So many people, including my team, did a lot of work about COVID-19 and IPV. We found in general some increases of IPV, particularly during the shelter-in-place periods, but then also COVID being used as a way for to exert coercive control. So one thing that I will share is, in some of the studies we did, people were talking about how their partner would take their stimulus checks or tell them that they couldn't seek health care, or try to take their children away or separate them from their children if they were frontline workers. So this is another way that a societal level trauma can cause more trauma and compounded stress for IPV survivors. Next slide, please. And so we've talked about this, but just to reiterate, we know that the perinatal period is a particularly dangerous and prevalent time for IPV. There's a study that showed that around 50% of homicides and suicides during pregnancy involve IPV in some way, and over 60% of those are with firearms. So this is a time in particular where it can be really dangerous and even lethal for IPV survivors. And like Dr. Hill said, there's a lot of association with multiple types of health outcomes. But I think that this really indicates that the perinatal period is a time where we can support IPV survivors and really work to leverage their strengths and social support systems and connect them with resources. Next slide, please. I also wanted to share that there are a lot of health disparities experienced in the perinatal period, particularly for people that identify as person of color, are non-English speaking, or living in poverty. So these are some of many different studies. One study showed that Black women are more likely to experience reproductive coercion, which Dr. Hill talked about, but is coercion around someone's reproductive rights and choices. That IPV is associated with postpartum depression, but Black birthing people, those living in poverty, and those who use languages other than English experience more depression and challenges with help seeking, and that Black pregnant people are more likely to be killed by an intimate partner. And so much of this is rooted in what Dr. Hill was talking about, which are intersecting systems of power and oppression and control at the societal level and the community level, which drive a lot of these disparities. And so I just wanted to put that out there, just to say that this is also an incredibly important time for us to be addressing health equity and disrupting some of these disparities that we see. Next slide. I want to share, these are some stories from survivors, and these are stories around perinatal economic coercion and substance use coercion. So substance use coercion is when someone controls someone's substance use or help seeking. So one person said, there was so much judgment and stigma attached. Look how worthless you are, different things along those lines, because you can't kick the cigarettes. You must not love this child and you must not love me. And that was what this person was hearing. And actually, there were also stories about how IPV survivors had wanted to ask for nicotine replacement therapy from their perinatal provider, and that the partner said, no, you shouldn't do that. You should be able to just, stop smoking without that help. I've also had situations where someone's urine screen was positive for marijuana, and it was because the person was coerced to use marijuana before the delivery, with the partner knowing that it would screen positive and indicate more involvement from folks at the delivery. This is another story from a survivor that's about economic coercion. So this is a person saying, I remember one day I was waiting on him because we didn't have any groceries and he did not come home until 1 a.m. I was aggravated and yelling at him. I couldn't feed my child. And this person went on to say that they thought that this is what led to them having an early birth, and they were in the middle of a high-risk pregnancy. And so this person had gone on when they were sharing their story to say that in their household, their partner did not give them access to the bank accounts and did not give them any access to money. So that is an example of how economic coercion can show up. And we know that the perinatal period is stressful and very expensive. So you can imagine if someone's experiencing economic coercion as well, how stressful that could be. Next slide. And then coercion around the birthing process. So this first quote is one from a healthcare provider describing how she noticed some partners really pushing to have for their partner to have sex earlier on than what was recommended for their healing. And then this other quote from a survivor about breastfeeding related coercion, which I had shared a story about already. So these, I just wanted to make sure that I was, that I was sharing survivor stories so you could see the different ways that coercion can show up during this period. Next slide. And then harm from systems. I am going to talk a little bit more about Child Protective Services. This person was talking a little bit about CYF. That's what Child Protective Services is called in Pennsylvania, but they were talking about using CYF as a form of control. And then this other person, this was an IPV advocate, they were talking about language-related coercion. And so Dr. Hill had talked about the importance of interpretation, but this person had said if the perpetrator speaks English and the partner doesn't, that can be a particularly vulnerable situation. And I've got to say that I've heard stories of survivors telling me that during every visit with the healthcare system, their partner was used as an interpreter. And it was only until their partner wasn't available that they finally had they were able to ask for a professional interpreter and they were able to share their story. So there's so much more to talk about trauma-informed interpretation. And during the Q&A later, happy to answer those questions or think through that with folks if you'd like. Okay, I'm just going to take a pause. I know that was a lot of stories and it was really heavy. So I just want to take a quick pause before I dive into the next section. All right, so now I'm going to talk a little bit about healing-centered engagement. So Dr. Hill talked about this, but this is really a way for healthcare systems to support survivors that leverages their strengths and gives them control back. So what I think is so hard is so much about IPV is taking control away from survivors. And then if the healthcare system inadvertently does the same thing, that just compounds the stress. And so I think our goal, and you'll see this throughout, I think all of the presentations today, is to support the survivor, amplify their strengths, connect them with social supports and resources, and really follow their lead in what they need. And every survivor, every person going through IPV in the perinatal period is going to need something different and want something different. And sometimes it may be resource connection, and sometimes it may be someone to listen to them. And no matter what they need and how, if we can support them in following their journey rather than us prescribing a journey for them to follow, we are really, I think, following a healing-centered pathway. So that is what I would recommend. And I know that's what Dr. Hill was saying as well. And I know it can be hard in healthcare because I think a lot of us like to fix things, and this is something where we really need to follow the lead of the survivor. Next slide. And so this is this idea of moving us away from what's wrong with you or even to what happened to you, but to really what is right with you. How can I help you? How can I assist you and support you in your journey, in your healing journey? Next slide. So, and you can actually skip this slide as well. So, Dr. Hill talked a lot about limitations of screening, and I'm going to talk a little bit about cues as well and how to implement it. But I want to pause here for a second and just really reiterate this point because I think it's very important. I know in healthcare, we love to screen for stuff. We screen for a lot of different things. And IPV screening, I think in general, is really problematic. One thing that I want to share is that studies that have looked at the prevalence of quote unquote positive screens for healthcare-based IPV screening have showed very low rates. So 1%, 2%, 4%. And we know based on the data Dr. Hill shared that we know that the percentage of people going through this is so much higher. And I think part of it has to do with the fact that healthcare is often not a safe space to disclose IPV. People don't know what we're going to do with this information. The other part that I think is important is that a lot of the screeners that are used do not ask about many different types of IPV, or I think like Dr. Hill said, really think of it as a checklist. And that's not anybody's fault. We're all incredibly busy. It's just very hard to integrate IPV screening in a way that can make it easy for somebody and safe for somebody to disclose. The other challenge with screening is in the screen and refer paradigm, we're really only giving resources to those who have disclosed that they're experiencing IPV. But we know that resources may be helpful for people that don't disclose. There's studies looking at social determinants of health screening that show an incomplete overlap between those who say that they want resources and those who say that they are experiencing food or housing insecurity, and the same thing is true for IPV. And we also know that it may not be that like I myself am experiencing IPV, but maybe my sister or my friend or my loved one is, and I want those resources too, so I can be supportive for people in my life. So I think that's where cues comes in. Next slide, please. Dr. Hill talked about this, but this is a strategy. There's other examples as well. There's one called PAIR, which is pretty much, it's similar, but it's another way to do this, that thinks about providing resources around IPV to everybody. And I think it's a really powerful strategy. So I'll say a couple things about it first, and then I'll dive into how to implement this. So one of my mentors and friends, Liz Miller, has done a lot of the really formative work with Futures Without Violence around cues. And Dr. Miller has tested cues in a lot of different settings, including family planning clinics, college-based health centers, and school-based health centers. There's still some work that needs to be done to test cues in other settings. One of my colleagues, Dr. Judy Chang, is an OBGYN, and she's done some testing prenatally. I'm working on testing cues in the pediatric setting. But I think it's important that you just know that there has been work, there have been randomized clinical trials on cues, but not necessarily in all the different settings where we're working. And the studies that have been done, though, have shown that people that receive cues versus usual care are more likely to report resource connection. They're more likely to feel more confident about harm reduction strategies, and amongst those who report IPV or dating violence at baseline are more likely to show a reduction at follow-up visits. The other thing that I think is really interesting about the cues studies are that even though cues does not really focus on disclosure, in the clinics where cues was implemented, there were more disclosures of IPV. And I think it's because you've set up a safe space to talk about IPV, and so people will feel comfortable disclosing. But as just a quick recap about cues, in the cues approach, you provide affirmation and universal education to all families, and then resources to everybody, and then additional support to those who disclose. Next slide. And these are really like the key essence of cues. It helps improve access to advocacy and resource connection. It mitigates some of the challenges around screening, including the disparities in who is screened and people's well-justified fear in disclosing. And it really is a very empowering approach. Next slide. So I absolutely do not expect you to be able to read all of this, and I have it more here so when you get the PowerPoint slides later, you can have access to this. But the way I think that is really helpful to implement cues is to have some scripting available for clinicians. Clinician's a very broad term here, whoever is going to be implementing cues. And cues can be implemented by nurses, by providers, by social workers, really by doulas. We're training doulas on how to do this, by really anyone. And there's many different ways you can implement this. So this cue script is one I use during well child visits. You can see that it doesn't only talk about IPV, it also talks about other social determinants of health. So this is a way to do it in a broader context where maybe just talking about IPV may not make as much sense. So this is one example of a script. Next slide. And here's another example that's focused on pregnancy. So this is a cue script we're using for one of my clinical trials, and it's one that that was adapted from one that Dr. Chang was using in the prenatal setting. And in this script, it's focused on relationship control, and it describes the multiple types of ways that IPV can show up. Next slide. And then these are scripts that are focused just on IPV. So this is something that you could use if you want to focus just on IPV. So one of the things on the resource list we talk about with everyone is stress in our relationships, and that free and confidential help is available. So you can see there's lots of different ways to do this. Next slide. And here are some ways to use cues if you have specific concerns. So this is an example of what you could potentially do if you were reacting to that initial story I told you. Sometimes when I see new parents feeding choices are being questioned, they tell me that they may not be able to make choices about how they want to take care of their infant. How does that feel to you? How does that resonate with you? So it sort of helps normalize why you're asking the question. And this is another example that we use sometimes for someone that's been coming in with frequent STIs that you can see. So this is a way I do this sometimes with, like, if I'm trying to ask about if a child is coming in with trichotillomania or something like that, and I want to ask about that, these are short ways to use cues to ask if you have a specific concern around IPV. So I just wanted to share lots of different examples. I will also say that With cues comes the provision of a resource guide, and there's many different ways you can do this. So you can have your own resource guide available that's tailored for your setting. Futures Without Violence has these great cards called Connected Parents, Connected Kids, which you could give to everybody. You can also adapt Connected Parents, Connected Kids to your own setting. So for example, in my clinical setting, I give people a resource sheet with lots of different resources, including IPV resources, to be less conspicuous about it, because sometimes there's other people in the room, not just not just the one parent or one caregiver, but it may be different in your settings. In the OB setting, it may look different than in the pediatric setting. So that's why I wanted to give you a lot of different examples, and the way that you give resources can also be tailored to your setting, but I would recommend checking out some of the Futures Without Violence resources, which I'll share at the end. So that is a little bit about how to make the transition from screening to cues. If you do use screening, you can use it with cues. So you can have cues first and then screen, and then you're really ensuring that you're offering resources to everybody. But what if somebody discloses? So I'm not going to talk a lot about this because I think Erica will be talking a lot about this, but just a couple things. When we've done studies that have asked survivors, what do you want from doctors and from healthcare providers after you tell us that you're going through IPV? The one thing that they say is, please listen. Just take a pause and listen, which I know feels simple, but I think it's really important. So what I recommend is, like, if you hear someone disclose, like, take a deep breath, get yourself in a centered place, because it is hard sometimes to hear those kinds of disclosures. And then provide validation and listening, and then warm handoffs to resources. But really allowing space for someone to share their story. And I'm a primary care doctor, so sometimes that space isn't in the moment for many reasons. And so then I do like a follow-up visit to make sure I'm giving space to the person to share their story. Next slide. And these are just some words of affirmation. Thank you for trusting me with your story. I'm here for you. And I know these are things that we know already, but sometimes it's helpful to have a couple scripts in your head, because I know it can be hard when you hear those disclosures, and just to make sure that you're feeling ready to provide that validation, I think can be helpful. Next slide. I want to now talk about a couple strategies to support survivors. So first of all, it's really important to not talk about IPV in front of verbal children or other family members. So sometimes for me as a primary care pediatrician, like, how do I get people alone to talk? So these are just some strategies. Sometimes I'll say it's a policy that I like to talk to everyone alone. This works really well in the postpartum setting, because you can say, I'd like to talk to the birthing person alone. I will sometimes ask the other person in the room to do something. So I'll ask them to fill out paperwork or registration or something like that. If I'm really having difficulty, I'll just ask everyone in the room to confirm their phone number, because then I have the birthing caregiver's phone number, and I can call them later, because sometimes you don't know whose phone number is whose. And doing that makes it it makes it less conspicuous that you're only asking for one person's phone number. Next slide. And so some safety planning tips. So I want to start by saying that if you don't feel comfortable doing safety planning, please don't worry about it. That is what victim services agencies are there for. That is their expertise. Like, sometimes when I'm talking to colleagues, I'm like, if we're concerned about something cardiac, we refer to a cardiologist. Like, victim services are a key component of our medical home, of our healthcare system. We're very grateful for them and their work. I think that if you don't feel comfortable doing safety planning, please just refer to victim services and they will do that. But just a couple things you can think about. So making sure you have their safe contact information, and if it's safe to leave a voicemail, if it's safe to leave it or to text. Determine what any emergent needs. One thing that I'll recommend is just reminding folks that on things like Find My Friends or social media, that is a way that people can track. So making sure like geolocation is turned off on Snapchat. Thinking about high lethality situations, I'm not going to get into this a lot right now, but just there are lethality assessment protocols, and those were studied looking at any sort of factor that leads to an increased odds ratio of intimate partner violence homicide. And I know this is really heavy to talk about. There has been no research to my knowledge to date that has looked at use of those in healthcare settings, and I don't actually recommend it right now, but it's important to just be aware that things like experiencing of strangulation, the partner saying they want to kill themselves or kill the IPV survivor, wanting to separate or leave the relationship, things like that are situations that can lead to higher lethality and just really important to connect to victim services. And then connecting to victim services, which we talked about. Next slide. And these are some safety planning for the clinic. So just a couple quick things. And by clinic, I mean healthcare system more broadly, whether you work in an outpatient clinic or in a postpartum unit or a labor unit. So confirm what is safe to document. So I think this is particularly relevant for anyone charting in a child's medical record, but just asking people what is safe to document, especially if someone else has access. Confirming patient proxies is really important, especially in pediatrics. I would never document when someone is in a safe location, like a shelter or at a family member's house that is a safe kind of location. I would just say they are in a safe location. When you're documenting IPV, in a note, I would, and I don't know how your medical record systems work, but I would just click the unshare button, and there is a specific reasoning for not sharing around IPV. So just make sure you're not sharing. And I would not add exposure to IPV on the problem list. I would not add it on the billing, the coding, any of that stuff, because all of that stuff does get transmitted to the patient portal in one way or the other, and we just want to be really careful about all of that. I mean, I think there's just now so many different parts of the medical record that we just need to be really careful about what we're documenting. But these are just some core safety planning tips to consider. Next slide. And now warm handoff to resources. So victim services agencies, we're so lucky to have them. And what I find really helpful when I'm trying to connect someone is to build that trust. So it is very, very hard sometimes to be connected to a group that you don't know, an organization you don't know. So I found them when I say, you know what, I work really closely with the Women's Center and Shelter. That's the group in Pittsburgh. They've helped a lot of parents or a lot of patients or a lot of people like you. I'd really like to connect you with them, and they can let you know your options and explore what might be helpful for you. When I say that, rather than just giving somebody like the number, I found that people feel more comfortable making that connection, right? It's not just this nameless, faceless sort of entity. This is someone that I, as their clinician, has worked with. So that kind of like that trust building piece, I think is really helpful. And hopefully this scripting can be helpful as well as you're thinking about making that connection. Next slide. Victim services, I've talked a lot about them, also called IPV agencies, domestic violence agencies. They started as grassroots networks in the 1970s and earlier. There's now over 1,800 agencies, including several incredible ones in the Bay Area, including Nextdoor Solutions, and Erica will be speaking more about their work. There's also culturally affirming agencies. There's many of them in the Bay Area too, and culturally affirming programs within agencies specifically for survivors with one or more marginalized identity. So next slide, please. And what I recommend really doing is when you're thinking about connecting from healthcare to IPV agencies, a couple of things. First, really get to know your local IPV agencies. Every IPV agency offers, or every victim services agency offers different services and resources. So here in Pittsburgh, we've got a few agencies that have emergency shelter, a few that have 24/7 hotlines, a few that have pet shelters, a few that have legal advocate. So really getting to know your different agencies and what they offer so you can provide referrals appropriately is great. And I also recommend considering developing a bi-directional relationship with your victim services agency. So IPV Health Partners, which is run by Futures Without Violence, is a great resource for how to do this, how to set up a memorandum of understanding, how to build a bi-directional partnership that could include training, more like detailed training. It could include warm referrals. Our victim services agency helped us come up with some processes and protocols for high lethality situations. So I would strongly recommend taking a look at this website for some guidance and support, and we can all probably talk more about that later too. Next slide. Okay, all right. So I'm going to take another pause here before I kind of dive into the rest of the talk. And hopefully now I think the last part of this is really thinking a little bit about some of the concerns around mandatory reporting. Next slide. So I think this is such a critical piece. And, you know, as a pediatrician, this is a question I get asked all the time. So I'm going to share a little bit about what the research looks like right now, and then some some guidance and support when you're grappling with these decisions about how do you support IPV survivors in the context of mandatory reporting. So first, I want to just say that there are studies that show that IPV survivors are more likely to have CPS reports filed against them, are more likely to be re-reported to CPS. And there are many, many studies that show this disparity. And I think that it's really important that we keep this in mind and we be really mindful about why we're reporting and what we need to do to protect the survivor and their children if we need to report. Next slide. And this is one of my favorite studies. It was done by, well, I shouldn't say that. There's so many incredible research, survivor-centered research done, but this was done by Carrie Lippy and colleagues. And I think this is a really powerful slide. And they surveyed over I think it was 2,500 to 3,000 IPV survivors that called into the National Domestic Violence Hotline about what they thought about mandatory reporting. Now, this was not all for Child Protective Services. There are, including in California, there are some states where there's other types of reporting as well. But I just want to share some of this. So when they were asked if they thought the report made their situation worse or better, you can see from this 1.8% thought it made the situation much better, and 51.2% thought it made their situation much worse. So I'm just going to take a pause there. Oh, sorry. Do you mind going back for a second? Just take a pause there because I think this captures so much of what the challenges are with this, right? A couple other key things. 1 in 7 were warned when reaching out for help that the person would have to legally report what they shared. 6 in 10 said the warning they received changed what they decided to say. And 1 in 3 have not asked someone for help because of the fear around reporting. And that to me is just, it's the gut-wrenching because we want to be here to support and help and advocate. And but I want to share this with all of you because I think it's really critical when we're thinking about this space. Next slide. So our team wanted to learn a little bit more about how do we best support IPV survivors when we have to file a mandated report. I'm making an assumption, but most of us are probably mandated reporters. And so first we asked folks, when should we file a mandated report? And we gave them many, many, many different scenarios. And then we asked folks, if we need to file a mandated report, what can we do to support the survivor? So I will say there was not a lot of consensus about when to file a mandated report. You know, always go by your state laws. But folks reached consensus that a report should not be made if there's exposure to IPV without co-occurrent child abuse and neglect. And while the two types of violence of course are co-occurrent, I think making the assumption that we should file a mandated report to Child Protective Services because of exposure to IPV is a really big leap to make. And I think we just need to be really thoughtful about why we're making the report and ensure that we're, following your state laws, but that it's in the context of child abuse and neglect. And these are just some quotes from the study. There's one that said, filing when there is IPV can seem punitive. And it's important to really empower the survivor. So then we ask people, next slide, please. How do we move? So this is, I guess, that we ask people, how do we support survivors? But in this context of how do we move from mandatory reporting to mandatory supporting? So this is Futures Without Violence. They coined this, and I absolutely love this term, mandatory supporting, because it takes us away from this idea that all we need to do is file a report to how do we actually wrap the survivor up in like love and support, recognizing that if we do need to file a mandated report, that there could potentially be escalation of abuse and some safety concerns. So I really love this idea of mandatory supporting. So next slide. And so this is a little bit of what came up from that Delphi study that I was telling you about. So just at the provider level, that we can inform the survivor that the report needs to be filed and why, offer the opportunity for the survivor to fill it out themselves or for us to do it together. Not using the word report is something that I recommend because it can feel really punitive. Making sure our medical documentation is safe and really connecting people to resources for safety planning because this can escalate abuse. Many IPV agencies have people that are experts in CPS in Child Protective Services. Like, for example, one of our local victim services has a CPS specialist embedded in there. So a great person to refer to if I do need to file a report. focusing on the child abuse or neglect, focusing on why you're filing the report, and then providing as much support as possible to the survivor, including safety planning, which victim services can do. And you can see there's some ideas at the hospital level and at the state level as well. I know in our state, there's been a lot of, I'm sure in California too, a lot of training for CPS workers around IPV and really thinking broadly about what are some non-punitive options to support families. Like I think the more we invest, and I know we all a lot of us feel this way, the more we invest in prevention and community grassroots solutions, the better. But these are just some strategies to think about if you do need to file a report, to really make sure that we're also providing that support, because to me, that's the most critical piece. Next slide. And then just to finish up, I want to talk a little bit about this idea of healing-centered systems. So a lot of the advice and recommendations I gave were at the provider level. It's all really important, and kind of Dr. Hill talked a lot about this too, but how can we make our healthcare systems more healing-centered for IPV survivors? And that is something that is a goal of so many of us, and I'm grateful to be part of a team of people that are just working day by day to make this a reality. I know it feels like a really big ask, but it's something that we are all working on together. So here are just some ideas. So I think the more we can develop comprehensive services and supports that are embedded within healthcare systems and that are embedded within community is important. Co-locating IPV advocates is a really, really great way to do this. And that means that having IPV advocacy programs in healthcare that allows the IPV advocate to actually come and talk with the patient, like in the healthcare setting, and connect them to community resources. One thing that I know may sound simple, but I feel like doesn't happen that much, and I just want to recommend it, is whenever you're making policy recommendations around IPV or putting together protocols just involving IPV survivors, getting their opinions, getting their thoughts, involving advocates, making sure that our protocols and policies and systems are being co-created by IPV survivors, that can really make all the difference. Investing in community medical partnerships, providing training to staff. So I'll say one of the things that I really recommend is thinking about training for all staff. So I know that there's sometimes training for like the nurses and the physicians and folks, but everyone needs to be trained around IPV. In my setting in primary care, sometimes it's our front desk staff that are the ones that get kind of the first call, or the ones that need to manage some of the nuances and challenges and support survivors. I had alluded to this earlier, but training interpreters around IPV. There's a lot of incredible work that's being done around trauma-informed interpretation that I think making sure that all interpreters have that training is critical. I think we just need to keep thinking about how do we make it possible to do follow-up phone calls with survivors, recognizing that the healthcare system in the moment may not be the right time or place or space for them to share their story. Invest the healing in healthcare teams. So this to me is so important. Sometimes the way we think about IPV is like our patients are experiencing IPV, but like a lot of our colleagues are experiencing IPV, a lot of our friends are experiencing IPV. And as someone who does this work, like, often people will come to me, like my colleagues and stuff, and ask for support for themselves or their friends or family. And so healthcare systems and clinics need to have support for employees who are experiencing IPV. And I'll give an idea of how to do that in a second. And then cross-sector collaboration. So we have in Pittsburgh, the Allegheny County and the mayor's office have a IPV task force, and it's very law enforcement and criminal justice heavy. But Dr. Miller, one of my mentors I was talking about earlier, she was able to get healthcare added to the task force. So myself and Dr. Chang and Dr. Miller and a few other folks represent the healthcare system, and these cross-sector collaboration meetings are so important. And victim services is there, of course, as well, but they're so important, and we can hear about ideas and share ideas, like we were sharing about how we could maybe use cues in like family law, and like because we know that at the time of a divorce or separation is a really dangerous time for IPV survivors. So just those cross-sector collaborations are great. Next slide. And I want to share the work of Standing Firm, which is an incredible organization run by an incredible person, Megan Rose. It is an organization completely focused on how do we help employers provide healing-centered spaces for employees around IPV. These are some statistics from their website around workplace violence events, that 83% of IPV victims or survivors report that abuse affected their ability to do their job. So this is an issue that employers should invest in, and Standing Firm actually has a consultative resource for employers to help them have a 360 view of their healthcare, their setting, in order to ensure that they are supporting their employees who are experiencing IPV. So I'm happy to share that connection to anybody who may be interested. Next slide. And I just want to end, I have a couple minutes. I just want to end with just sharing a little bit about a study that we're working on that I thought would be of interest. So next slide. And these are all of the co-investigators. It's a great team. And then next slide. And these are all of our incredible community partners from all over Pittsburgh and the US that we're working on this project with. So this study is focused on training doulas around supporting IPV survivors. It's a clinical trial where we're actually going to be either connecting someone to a perinatal IPV survivor to an IPV trained doula, or to an active control group. And we'll be learning a little bit more about how doulas can support IPV survivors. This work originated with some interviews with doulas. These are some examples of how they were already supporting survivors. And so these are just some quotes from them. Next slide. And then we did a systematic review of the literature to learn more about clinical trials where doulas were involved. There was a lot of sort of heterogeneity in study design and outcomes evaluated, but a lot of the outcomes actually did focus on mental health. And there just weren't that many funded trials, including doulas. I mean, it's been an underfunded resource, despite the incredible amount of evidence about how amazing doulas are in terms of supporting perinatal people. So we're excited to be able to do this work. Next slide. We also found that not any of the studies actually focused on intimate partner violence. So using these sort of formative pilot data, we were able to get funding to run this clinical trial. Next slide. So the aims of the studies will be evaluating the effectiveness of an active control compared with an IPV-trained doula. We're working with a community-based doula organization in Pittsburgh to run the doula program. And then we're going to be looking at mediators and moderators, so things that may impact the effect of this intervention, and then some implementation as well, how we can best implement and sustain these programs. Next slide. This is our conceptual model. I'll move past this, but just looking at kind of we do this. And I wanted to share, as part of this study, we put together a really robust survivor-led training for doulas on IPV. And these are a little bit, this is our website. But if anybody's interested in getting access to this training, the training is done. The trial is about to start, but the training we've finished. We had training on culturally affirming care, LGBTQ+ affirming care, safety and support, healing-centered care. The training was a range of videos. So it was 6 different videos and several podcasts as well. And every video starts with a story, then has some didactic, and then ends with a mindfulness moment. So this is an example of one led by one of my dear friends who is an anti-racist yoga teacher. So she led our mindfulness moment. So if anybody is interested in seeing the training or would like to give feedback on it or even use it, please let me know. And then next slide. And then I'm excited to hopefully come back and share the results of our study. So just to finish up in my last few minutes, so some action areas: developing a universal education script for your setting. Learn about all the victim services agencies in your region. Just call them. They're all incredible and would love to talk with you. Developing a formal bidirectional partnership. And like I said, the IPV Health Partners website can help. Implementing training, and then advocate for policy level and institutional healing-centered approaches, including having support for employees experiencing IPV. Next slide. And these are just some resources for caregivers. These are those cards I was talking about from Futures Without Violence. Next slide. Some resources for clinicians for all of you. I do want to just share, I put both the ACOG and the American Academy of Pediatric guidelines on IPV here. And then next slide. And then this is once more the IPV Health Partners. Next slide. And then this is it. I just wanted to also just share again the number for Next Door Solutions. And I think I'm at time, but thank you so much.
All right, so we're gonna get started. I hope everybody had a good break and you were able to get some water, do a little stretching, get some coffee since it's still early in the morning here in California. Well, we're going to go ahead and get started. So my name's Erica Villa. I'm the Associate Director of Community Partnerships for Next Door Solutions to Domestic Violence. So I'm going to be talking now from the domestic violence service provider side and what we see from our end. And before I get started, I want to share a little bit about why I do this work and why I think partnerships with medical providers is so important. Actually, before I started working on Next Door Solutions about 13 years ago, I worked in the medical sector. I was responsible for doing follow-up care for positive results for a community clinic. And something that I saw there and that stays with me and actually carries the work, carries the importance of why partnerships are so important with the medical sector was one particular case where this was a woman, an older woman coming in for treatment for chlamydia. This was the 6th time this patient was coming in for treatment. And this individual only spoke Spanish, so one monolingual Spanish speaker. And one of the things that she said, and I was translating at the time, I was interpreting and translating information for her because the medical assistant had gone on break. And so that usually was in my role. But because I was responsible for ensuring that our patients receive treatment for sexually transmitted infections, I was doing the translation interpretation. And so when I was giving her the pills for her to take, one of the things that she told me was, well, he says it's my fault. I'm the one that's sleeping around, and he doesn't want to use condoms. And so I shared this information with the medical provider, and the medical provider, very concerned, said, well, let her know that she's going to get pelvic inflammatory disease. It's going to affect her reproductive organs, and that she needs to stay away from intercourse for 2 weeks. This is her 6th time. So I went back and I told her this information. And after that, I talked to the medical provider and the medical assistant, and I shared, I'm like, I'm really concerned because this is her 6th time. Is there anything else that we can provide to this particular patient? And the medical provider said, yeah, I'm going to give her a list of resources for her to call. And that was that. And that story stayed with me until I started working at Next Door Solutions, where it was like an aha moment. I said, she was in an abusive relationship. It wasn't physical, but there was a lot of reproductive control. And so that really led me into pushing our organization to partner with medical providers and the medical sector overall. So that's a little bit about why I am here as well. Next slide. So before I get started, I also want to give a shout out to all of our sister agencies, the 5 domestic violence agencies that exist here in Santa Clara County. And the reason for that is because we are the only standalone domestic violence agency, but our sister agencies also provide other services such as focusing on human trafficking, sexual assault, and also some of the organizations focus on particular groups. For example, AKI, Asian Women's Home, focuses on the API community, as well as Maitri focuses on the South Asian community. Community Solution also focuses on farm workers. So we all work together to support the needs, not just for domestic violence survivors, but also for survivors of human trafficking, sexual assault. And we also collaborate with regional and state victim service providers as well to address the needs for overall survivors of gender-based violence. So a little bit about Next Door, just how it was mentioned before, we actually got started in 1971. And I am really proud to say that we were the first domestic violence shelter agency to offer bilingual services, English and Spanish, and the 2nd domestic violence agency in California. And just like everything else that gets started in the Bay Area, we actually got started off in a garage. Our founder, B. Robinson Mendez, got together with a few of her friends, and they talked about the issues that were the lack of services for domestic violence survivors. Her being a survivor herself, wanted to address those needs. So in the 1970s, there was a lot of movement around women's rights, the feminist movement. And she really wanted to focus on, well, what about the women of color? And so that's how our agency got started. We actually got started off in a garage, and we established our hotline number, and we've been using that number ever since. And so our mission is to end domestic violence in the moment and for all time. And I really believe in our mission, appreciate our mission, because not only does it have intervention, but it also has prevention. So in the intervention side is in the moment, right? Addressing what the need is for survivors right now. And then for all time is our prevention, is addressing those systems change that needs to happen. And our vision is we seek a community environment that breaks the silence and makes domestic violence and other forms of gender-based violence unacceptable. And we do this through comprehensive quality services, survivor-defined advocacy, collaborative strategic initiatives that target not only the individual, but relationships, community norms, and the societal attitudes. So this is a snapshot of the services that we provided last year. So overall in the county, we answered about 20,000 calls. And the individual service provider, we answered 14,000 of those calls. So that's a huge number of calls that we get through our 24-hour hotline per year. We also provided over 6,400 bed nights for survivors and children via our shelter and our hotels. And we also housed in 5 pets at our shelter. So our shelter is for women and children, and we are grateful that we're able to provide hoteling for men and for those that identify from the LGBTQ community that are needing shelter for the night. We also provide walk-in services, and we helped over 1,000 survivors to receive crisis counseling through our walk-in services. And additionally, we served over 2,000 unduplicated clients throughout the year that we provided different services such as legal advocacy, housing assistance, support groups, healing services, which I will talk about shortly. So in a nutshell, these are our services. In order for someone to get a hold of us, they can do so through our 24-hour hotline or come into our main office for services. Our emergency shelter, we house 9 women and children, so overall 19 individuals. Here in this county, we have 62 shelter beds, which doesn't sound like a lot, and it actually isn't a lot. But the thing is, shelter is a Band-Aid, so we need more long-term services, housing services for individuals, which brings us to our housing services and assistance program. So through this program, we help individuals stay away from shelter. So if they have safe and stable housing, but due to the domestic violence, they're about to lose it, either because they can't pay rent or they're having to deal with legal aspects of the domestic violence, we're able to support them and in that way. In our walk-in crisis intervention counseling, anyone can come in as a walk-in, no appointment needed to talk to an advocate and begin receiving services. They can also call if they're not able to make it in person to receive services as well. We offer over 15 support groups, either virtually or in person, and they're open to those who are in need, and they're cyclical. So every week we have a different session, and once somebody attends group for 14 sessions, 14 weeks, they receive a certificate of completion. We also have a partner that provides therapy services. So if an individual is not able to access therapy services elsewhere, they're able to connect with us. And these therapy services are for those individuals that either aren't able to pay, or they don't want their partner to find out because of the insurance, or they're undocumented and have some fears. Those therapy services are specifically for those individuals. We also provide legal advocacy and systems advocacy. Legal advocacy looks like, for example, helping individuals apply for restraining orders, receive immigration relevant information, information around child custody, or we're also navigating and working with law enforcement. We also have the systems advocacy, which is advocating for individual through the systems. For example, we have a partnership with the Department of Family and Children Services. So oftentimes when there's a report, we talked about mandated reporting, oftentimes the Department of Family and Children Services gets involved. So we support survivors navigating that system. And we also provide ongoing support, which is case management, but we don't call it case management. We call it supporting the survivor ongoingly for long term. And we don't even use that term as well with the survivors because we don't want no one to think that they're being managed, right? We want to empower them. And we also provide other healing services such as workshops. For example, parenting after violence, that's a workshop, particularly for parents who have had an incident and want to enhance that communication with their children and talk about what happened with their children. And then we also provide youth and teen violence prevention services. So we actually have a youth leadership cohort where young individuals who are interested in promoting healthy relationships with their peers create social media content, lead workshops, and also speak on the topic around teen dating violence. And then the community prevention and education program is providing presentations out in the community around the impact of domestic violence, participating in webinars such as this one, collaborating with other organizations and providing training as well. So now how does someone get to Nextdoor? Well, either they call the 24-hour hotline or the walk-in crisis. And really, clients in the crisis mode, the last thing they want and they may want and think about is their strengths. They may not think that they have any strengths. And so our role is to provide that advocacy. And that advocacy looks like helping a survivor navigate systems, provide unconditional support free from judgment, guide them, contact and make connections with other services and other systems that the survivors identify. So it is important to make certain that we advocate for whatever the survivor chooses, that we honor the choices they make, even if we don't agree. And that's really at the core of our model of providing services. We're very survivor defined, client defined, meaning that they're the experts in their lives, and we're here to support them and help them navigate, provide that information and education so that they make the best decision for their situation. And when we talk about crisis intervention, this is working with the survivor to de-escalate the emotional stress, especially when there's a traumatic change in their life. Crisis can tear down a survivor's resolve and ability to make a decision until they are unable to see the situation outside of the crisis. So what would that look like? That would look like providing immediate relief for pain, problem solving, helping them look for coping skills, develop new ones, mobilize whatever resources are necessary and available to meet the crisis situation. And then we safety plan. We talked about safety planning. So this is looking at what is the risk, what is affecting the survivor's safety. And safety can mean very differently to me or to the survivor. So for example, for me, financial safety might look a lot different for what it would look for the survivor, as well as the physical safety, safety around their children. And so it's really looking at those, we call it the life generated and the batterer generated risks. So the batterer generated risks are really, what are those risks around the abuse? How is the abuse impacting their overall life? And then the life generated risk is looking at how is the abuse affecting their basic life needs like housing, education, employment, finances, their overall wellness, health access. So we look at that, and that's part of our ongoing support that we provide to survivors. So when we're meeting with survivors, the first thing we do is discuss the situation. What are they coming in for? And we go based on what the survivor is really willing to share and really establish that rapport. Also, one of the things that really helps us is that we're not mandated reporters. That's not to say that we won't make a report, but it's an agreement. It's a conversation that we have with the survivor. But we do not report, we do not call law enforcement unless it's something that the survivor needs or wants to do. And so we also assess the risk. So safety is at the core of when we're providing services. And then we create a safety plan around what is important, what is the goal of the survivor. And we provide education. So for example, if the survivor is wanting to go into the shelter, we talk about, okay, what are your concerns going into the shelter? How would you feel sharing the space with others? What is it that you need to take from your house? Do you need to go back? So we ask a lot of questions, open-ended questions, and wait until what is important and what the survivor wants to share. And then we discuss the possible outcomes and the next steps. So what would it look like going into the shelter today? Or do you need to go in tomorrow? So it's all of those things all around focusing around the safety. So these are two of the pathways for our services. So in both hotline and in person, the goal is to show care and support for the survivor. And this can look like the care, can look like thanks for reaching out. Because oftentimes for us, what we consider success is when someone either walks in through a door or calls a hotline. That in itself is already a success because they're reaching out to seek the help that they need. We also show care by asking, are you in a safe place to talk right now? Is it a good time? Or do you want to call back? How are you taking care of yourself? So that's how we show care and support. It can show up by asking, why don't you tell me more about your situation? What's going on? What have you considered so far? Let's brainstorm together. What else is in your mind? And then they follow this pathway, and that usually happens in the intake and assessment of needs, and also connecting to an advocate. And what is really important is establishing that rapport with the client, because oftentimes there's a lot of fear, especially if they don't know that we're not mandated reporters, if they don't know that we don't work with law enforcement. So once we go over that everything is confidential, we don't share information with anyone, then that kind of eases and calms the survivor down. And then they receive the services that they need. So oftentimes there's a lot of fear, right? We talked about mandated reporting. So there's a lot of fear of being targeted in an investigation and losing their children in the process. That's one of the biggest concerns. And what's interestingly enough is that oftentimes that is the reason why a survivor seeks help, is because of how it's impacting their pregnancy or it's impacting their children. And oftentimes we see a lot of survivors coming in either when they're pregnant or when their child is witnessing or being exposed to the abuse. Oftentimes they regret the decision to report the abuse, particularly to law enforcement, or being reported even in the medical sector. When we have them come in, they're like, it was reported, now I'm having to navigate the criminal system, I'm having to navigate the court system, I'm not sure what to do, and they're really, really, really overwhelmed. So our role is to, calm them down and help them navigate all these different systems. When they're interviewed, they're hesitant to disclose the information because they're not sure what's going to happen, in particular in the medical sector. They're not sure of what kind of worms that's going to open up for them. And oftentimes, when attempting to leave the relationship, it can become the most dangerous time. And that includes reporting the abuse. It often takes 10 times or even more, but on average 10 times for a survivor to leave the abusive relationship when they actually do. And it's because the person that's being abusive is going to do whatever it is that they can to get that control back from the survivor, that power and control. So they're going to try and do everything, use everything in their power, whether it's immigration, whether it's, even the pandemic, they leveraged on the pandemic to gain that control as well. So anything, especially if there's external factors, that can also increase the abuse and the concern for the survivor to leave the relationship. There's also risk of homelessness. Depending on where the survivor lives, for example, here in Santa Clara County, it's very expensive to live here. And so if they're financially dependent on the person that's causing harm on their partner, it can be very hard to leave the abusive relationship because of lack of housing, assistance with housing, or not having income. That can make it very difficult and challenging for survivors to leave the abusive relationship. So what's really important here and what really works, talking from the medical sector, is providing universal education, because oftentimes when survivors come to us, they're already in a crisis situation, but everyone goes to the doctor at least once a year, if not for ourselves, for our children. And so those are opportunities to connect survivors sooner rather than later to services. So healthcare providers can be a lifeline to those survivors that are experiencing intimate partner violence, and especially those survivors that are the most vulnerable. I'm talking about the ones that are undocumented, farm workers, those that are from smaller groups that may not necessarily know their rights in this country, or the rights, or know the system, what the rights they have in order to receive services. So one of the really great things, and this is an example of that tool that can be given, that we've been talking about, the CUES model, providing the universal education through giving out a resource. So this is a picture of that safety card that can be given out. And so really that's the messaging, providing the resource to everyone, even if they don't disclose, because then if something changes in the relationship, they know where to get help. Oftentimes, by the time that they come to us, they're in a crisis situation. They're very overwhelmed, but if they know the resource sooner rather than later, they're able to plan and leave the relationship or leave their house safely without any repercussions. So there was this research done, and this was done through Futures Without Violence, that victims, survivors who talk to their healthcare provider are 4 times more likely to use an intervention, for example, calling a hotline, seeking counseling, or going into a shelter, than if they talk to a family, friend, or other providers. So it's very critical that medical providers are trained to respond safely, sensitively, and effectively to disclosures of domestic violence. And in order for medical providers to do that, there's different ways, there's different things that can be done from the medical sector. So I'm going to talk a little bit about what we've done, what partnerships we've had with medical providers. So one of the key things to do is to have a memorandum of understanding. And what that is, it's a formal agreement of the roles that the domestic violence agency is going to play and the medical provider. So for example, one of the memorandum of understandings that we had with a few clinics was that we would provide cross training. For example, we would go in and provide training on what the domestic violence experience is for survivors, and talk about the power and control and that overall experience. And they would come in and talk about blood pressure, heart attacks for our shelter advocates. And one of the things that we really received that was really great, we got trained on how to talk about taking Plan B, the day after pill, how to use condoms, how to talk about options counseling when someone is pregnant. And so And then also family planning. So how do we start talking about birth control? So we have a birth control kit that we also use. So because we're also considered a wellness center. So that can be an example of the cross training that is done. We also train service providers, medical service providers, on how to incorporate the CUES model. And we provide that technical assistance throughout the workflow change in the clinical setting. We also provide consulting. We have some doctors that gives us a call and does a what if case scenario, or they call us and say, hey, I have this situation with this patient. Is someone able to come in? Or is someone able to come in person and talk to this individual right now? They're in a high lethality situation. And that's where we provide the mobile response. That's what we call the mobile response, is sending an advocate over to talk to that patient, especially if they're in need of shelter in that moment. We also have different partnerships with different medical sectors. So we have doctors and residents from primary care, from OBGYN, and pediatric residency that come into our facility and learn about the services that we provide and how to connect their patients to our services. And that also is an opportunity that we talk to the doctors and the residents about the CUES model, the CUES intervention. And so it works really well because they're able to come in and see firsthand how we provide the services. And oftentimes the feedback that we get is, wow, I didn't know that the domestic violence service providers did all these kinds of work. And so it's really great because it gives you that firsthand experience. And I also encourage everyone to call the hotline. Call the domestic violence hotline that is near you to get familiarized. That is the first step, because when you have somebody disclosing, saying, yes, I am going through this, you have to know where to refer. We had survivors tell us and share with us that when I told the doctor this was happening, they didn't know what to do. And I had to wait, and they had to call the social worker, but the doctor froze. And that made me feel very uncomfortable. So very important to know where you're going to refer your patient. Presentations and trainings, that's also another thing that we provide. Sometimes those are one handoff. So medical clinics gives us a call or contacts us and say, hey, I want you to come and talk about the services you provide and how we refer. For example, also one of the things that we do have, particularly for our shelter, is the bidirectional warm referrals. So when we have patients or individuals coming in and staying at their shelter, they might have forgotten their medication. They might have not been able to bring any medical devices or any things like that that they may need. And so that's where we also lean on to our partners, our medical partners, to be able to address those needs for survivors. So giving them like a week prescription before they go and see their doctor, and also working with the medical providers, and particularly when someone is pregnant. A few months ago, we had a survivor that was pregnant. They were in their 8th or 9th month already, and so we had to work really closely with their medical provider to ensure that they went all the way to full term, and they were able to receive the medical care with the understanding of where they were staying at, which was our shelter. And then there's also, this opens up to funding opportunities. We've partnered up with a network of clinics to provide a learning network and to talk about best practices and how they could incorporate the CUES model. We also have had where an advocate is co-located in the medical setting, ready to take the referrals of anyone that disclosed or anyone that wanted to talk to an advocate and get connected to services right away. So these are some different models that can work in the medical setting to enhance that accessibility to services for the survivors. And also what's important is funding to be able to provide these, right? So what the first thing that survivors often need is support for years, not weeks. Leaving an abusive relationship is rarely a one-time event. It's a process. Many survivors cycle through crisis, stabilization, and rebuilding phases. Long-term case management, like the ongoing support that we provide, counseling, legal advocacy, housing stability, and economic empowerment services are essential for survivors to move from safety to stability. Without sustained funding, programs risk shutting down midway, leaving survivors without the ongoing help that they depend on. Also, continuity builds trust and safety. Survivors are more likely to engage with services when they know support will be consistent. High staff turnover often caused by unstable funding can re-traumatize survivors who have to retell their stories to new staff over and over. So having stable programs can build lasting healing relationships with advocates and service providers. Also, advocacy ensures systems respond effectively. For example, domestic violence is not just an individual issue, it's also tied to housing, healthcare, immigration, child welfare, criminal justice system. So having advocacy can help get the funding for shelters, get funding for paid leave for survivors, protect them against evictions. It also can help secure laws, protections, and overall resources. So, for example, right now, with a lot of immigration conversations, we're advocating for our partners to receive funding to help the needs of survivors who are undocumented. We also incorporate that as part of the safety planning when we're providing services. So right now we're having to do a lot of safety conversations around immigration. And then prevention and community education needs to be consistent. So prevention is very, very important. And when funding goes away, oftentimes prevention is the first thing that goes away. But prevention is very important because you can engage youth at a younger age. You can create healthy relationships, curricula. So for example, the parenting after violence workshops that we provide, that is prevention. That incorporates some prevention so that we break that intergenerational cycle. And sustainability protects against funding gaps. So many domestic violence agencies rely heavily on competitive grants and short-term contracts. So when funding lapses, critical services like hotlines, shelters, and legal support are at risk. Last year, we lost some of our funding for legal services. So before we used to have attorneys on site that can provide case consultations, and now we have to refer out because we lost that funding. So funding is crucial and it's important because it's not just a one-time event. It can take years for survivors to get through that journey of healing. And so if you have any questions about anything on how to partner up with domestic violence agencies, you can reach out to me. You can give me a call and we can have a conversation.
Thank you so much, Erica. That was a fabulous presentation. I really appreciate you. So now you and I are going to spend some time together answering and discussing a few frequently asked questions. Before we jump into those, I did see a few questions come in the chat about your service area. Folks are really curious if you all have branches outside of Santa Clara County.
We do not have branches, but we do partner up with a lot of other victim service providers. So for example, sometimes we have survivors calling from Texas, calling from another state, wanting to flee and relocate to California. So we may start that process through the phone line, or we have survivors wanting to relocate from California somewhere else, and we'll start that contact process. But I would say there's contacting the National Domestic Violence Hotline. You can find out what service provider is in your area. Because laws change from county to county, from city to city is very different. So it's also important to connect with service providers within your area because of the changes within the laws.
Got it. Thank you so much for that clarification. And you also showed a safety card. Where can folks find that?
So the safety card can be found through the Futures Without Violence website. These safety cards, I think Maya mentioned that she uses the one Connected Kids, Connected Parents safety cards. So there's different safety cards that have been adapted to different medical settings. There's one for primary care, there's one for OBGYN, there's one for pediatrics, there's one for prenatal care. And so when you reach out to Futures Without Violence, it's very easy. You can order online, and the only thing that they charge is for shipping. So it's a really, really great service that they provide.
Amazing. Thank you for that. So let's go ahead and move into a couple of questions. So, from your experience, what is one thing healthcare providers often get wrong when addressing IPV during the perinatal period?
I think providers sometimes treat intimate partner violence screening like a checklist instead of a conversation. During pregnancy, trust is everything, and survivors may not open up right away. If a provider rushes or doesn't create a safe space, it can actually shut down someone. The biggest shift happens when a provider slows down, normalizes a topic, and offers support without pressure. It's about relationship building, not just asking the question. So that's why I really appreciate, the Q's model, because it's not about getting that disclosure. And oftentimes that's the focus, right? Are you? Yes or no? Or even the way body language is very important. There's been times when I was receiving prenatal care, I was asked, I was even apologizing, I'm sorry, I have to ask you these questions, right? So it's more about, hey, I'm asking these questions because this is something that is very common in our community, normalizing it, right? Trying to reduce the stigma of this uncomfortableness is very important. And so making it more comfortable and focusing on building that trust with the patient, especially during pregnancy, is very important, because oftentimes, and what we've noticed from our end, is survivors are coming in when they're pregnant, and talking to our survivor advisory board, most of them mention, my abuse escalated during pregnancy, and I was so scared and I was so afraid, I didn't even know what to do. And oftentimes, even survivors say, well, I don't see this as a health concern. But being able to make that connection, that this can impact your health, your relationship does impact your health and that of your child, I think that's very important to do. So for me, it's, do not treat this as just a checklist, as just getting a yes or no answer, but it's more of like, hey, I'm giving this. How are you doing at home? How are you doing in your relationship? We're giving this information. Let's read one of the panels. The good thing about the safety card, it has panels. And so you can read it together and say, is this something that's happening to you or you want to talk about? And that opens up. It's kind of like screening, but it's adding more to it, more depth.
Thank you for sharing that. That's a great answer. Um, how can providers use the Q's model effectively without compromising patient safety or autonomy?
Well, cues works best when it's done universally. So meaning that you share the information with everyone, not just with those that are ready to disclose. I didn't mention it in my presentation, but when Futures was doing a study, one of the things that came out was that only about 25%, let's say 100 individuals are screened, only about 25% disclose, right? And so those 25% are usually the ones that get the resource. But what happens with the other 75% that said no, right? So that's really more of my concern, because oftentimes these are these individuals that are afraid of being reported, that are afraid of their immigration status, they are afraid of the unknown. What's going to happen if I say yes? How is my partner going to react, right? So really, for me, the importance is not um, about about screening, but giving the resource to everyone, even if they say no. That's really what's important. So you're not singling out anyone. right? And something that the provider might say is, I'm sharing this with all my patients because relationships do affect your health. And then offer the resource card that they can keep. And then also, what I really appreciate about the model is the empowerment piece, where I'm glad that where you can say, like, I'm glad that this is not happening to you, but here, take it anyway, because we all know of someone that's having difficulties in their relationship, and you can share it with your sister, with a friend. Um, and it's simple, it's confidential, and it puts the power back in the patient's hand, which is exactly where it belongs.
I love that. Can you talk to us about what it looks like when a provider does use the CUES model effectively? Like, what changes do we see in survivors?
It definitely builds trust. And we actually had one survivor share that when her doctor asked her, saying, "Hey, how are things?" She wasn't in a relationship at that time. She had already left her abusive relationship. She had just left the abusive relationship. She was actually staying at our shelter. And so when he asked, and um, it it was the CUES model, and it was one of those clinics that had adopted the model. And so when he asked her, saying, "Hey, how are things at home? Are you in a relationship? I wanted to give you this card." And when the patient disclosed, saying, "Well, you know what, I'm actually staying at Next Door Solutions Shelter," and he was familiar with us. And so he even said, "Oh, yeah, I'm familiar with that organization. I'm glad that you're receiving help. Is there anything that I can do for you?" And because of the abuse, she had received multiple hits. So he actually ordered an MRI. And then now, even now to this day, he follows up with it's her primary care doctor. He follows up with this patient particularly, and he has incorporated and made the domestic violence part of her care plan. So he sometimes follows up every quarter, she told me, just to see how she's doing emotionally. I mean, this is going far and beyond, but this is one example of when the model is used well.
That's beautiful. So beautiful. Thank you so much for sharing. I also see another question here. Does Nextdoor or Futures Without Violence offer programming for young men, fathers, or male family members?
Absolutely. We actually, for our, I didn't talk about this, but for our prevention programming, we actually work collaboratively with schools. There's this particular program called Coaching Boys into Men and Athletes as Leaders. So these two programs, particularly, is working with mentors, and mentors meaning coaches, really from the schools, where they can incorporate 15-minute conversations with the athletes that talks about healthy masculinity, locker room talk, consent, those type of things. And the athletes as leaders is a complementary component for those who identify as female or from the LGBTQ community, and talks about self-esteem and empowerment. And so these two programs work really well, particularly with athletes, because athletes in high schools are the trendsetters. So these programs are done for middle school and high school, and so it's a really great programs that can have that conversation and prevent some of these unhealthy characteristics in adulthood.
Got it. Thank you for sharing that. And then as we wrap up, at the beginning of your presentation, you shared a bit about what brought you to this work. Can you tell us a bit about what keeps you doing this work?
What keeps me doing this work is really being able to see the trajectory of a survivor, moving from crisis to safety, stability, and self-sufficiency. It's really nice. One of my favorite places to really see that is during the support groups. Um, if anything, I would suggest and recommend for you all to refer your patients to support groups, especially during pregnancy, because oftentimes during pregnancy, they may not have a support system, especially if, let's say, if they're undocumented, if they've been very isolated, they don't have family. Um, it can build that support, that network of support. So, for example, in our support groups, they celebrate every month, they celebrate their accomplishments. Sometimes they come in early to have dinner together. And so it's really nice to be able to see that. And oftentimes they talk about self-esteem where I came in, I looked dreadful, and now look at me. Sometimes they come in dressed like they're going to a gala to support group because it's something that's helping them get through whatever the situation is.
Thank you for sharing that. So now I think we're going to get ready to transition to our next speaker. So we have Anastasia, who is going to be joining us.
Fantastic. Thanks, everyone. And I will just wait for the slides to come back up. Just a reminder that the question and answer period closes in about 15 minutes. So make sure you drop in your burning questions for that Q&A session. And now that we've heard about various approaches to intimate partner violence and some of the resources that are available, we're going to talk about specifically benefits and resources that are available for Medi-Cal members. Here are some objectives that I'm not going to read out in the interest of time, but they'll be on the slides for you. So before talking about DHCS's approach to intimate partner violence, I want to acknowledge the commitment the department has to the entire birthing care pathway continuum. So hopefully most people at this point, if you're in California, and I know there are many people who are not, have heard of the birthing care pathway, which was released in a report in February of 2025, and is a comprehensive policy and care model roadmap from conception through 1 year postpartum. The roadmap includes 42 policies that address individuals' physical, behavioral, and health-related social needs. About half of the policies discussed in the report are already complete, and half are in progress to be completed within the next year. Within these policies, we've included several that focus on intimate partner violence screening and approaches that I will dive into in a second. What's important to note and to frame the discussion is that what came out of some of the birthing care pathway stakeholder interviews and focus groups was that all patients, providers, and community-based organizations shared that IPV screening was inconsistent, had limited follow-up care or support for resources. Patients were concerned about many perinatal providers lacking the training to conduct IPV screening, despite what we've heard about, and that fits with kind of some of the discussions that we've had today. So the first policy on the next slide that focuses on IPV is that DHCS requires all Medi-Cal managed care plans to adhere to all USPSTF grade A and B recommendations, which does include screening for IPV in all reproductive aged women and referring those who screen positive to additional resources. Thus, IPV screening is a covered Medi-Cal benefit, and it is up to the plans to ensure that their contracted providers and organizations are doing this. DHCS evaluates whether these plans and clinics are doing this screening and is reflected in some of the medical record review requirements, which are conducted on a biannual basis. In the future, in the next year, as part of those birthing care pathway policies, more guidance on screening will come as DHCS works to improve implementation of screening in the required assessments under programs that we have, such as the Population Health Management Program or Comprehensive Perinatal Services Program, which many people know as CPSP. Next, DHCS recognizes just the knowledge that's in the community and the expertise for this patient population. And you've just heard from Erica about all of the expertise that she holds in one organization. And so we really want to connect that knowledge and experience with our plan partners. And so one emphasis for the plans is really contracting with community-based organizations that have expertise and experience in serving populations affected by IPV. These services that we have, or once community-based organizations are connected with managed care plans, they can provide enhanced care management and community support services, which are eligible to specific individual populations that we'll talk about in a bit, and really emphasizing that plans need to build out these referral networks for this population. And then finally, DHCS recognizes the need to approach many issues, including intimate partner violence in a trauma-informed context. A lot of energy and effort has been put into trainings on the ACEs Aware website that include a number of trainings on how maternity providers could use a trauma-informed care lens, and more work will be done at the DHCS level around how to approach trauma-informed contexts in the future. And just acknowledging that ACEs Aware is not the only place that you can get resources, as we've heard about many of the resources available for training previous to this. So those are the 3 policies within the Birthing Care Pathway Report that address IPV. And now I'm just going to highlight some of the DHCS policies that could support populations experiencing intimate partner violence. So hopefully many of you have heard about ECM, or enhanced care management, at this point. It's been a benefit for a couple of years. And ECM really is, the goal is providing a single person, so a care manager, who delivers comprehensive case management and coordinates health and health-related services across the delivery system. So among social systems, physical, medical systems, the behavioral health system, et cetera. ECM is the highest level of care management for Medi-Cal members. And importantly, as I mentioned, ECM services are delivered primarily by contracted community-based entities. And so those community organizations who work with those individuals who are affected by IPV can qualify to become providers and have some of their services reimbursed under Medi-Cal as a separate financial stream for some of the work that they do. So who is available for ECM? One note to flag is that in order to be eligible for these services, a member has to be a part of a specific population of focus. These are currently all 7 of the populations that one can qualify to receive ECM services. However, the highlighted populations of focus that a member may be eligible for when experiencing IPV are circled in these red lines. And so just to call them out, individuals who are pregnant or postpartum through that 12-month period and fall into the birth equity population of focus, which includes specific racial and ethnic disparities as defined by California public health data. That's number 9 here on this chart. Individuals experiencing homelessness or housing instability, and of note, that includes those individuals fleeing domestic violence, dating violence, sexual assault, and other things like that. Individuals with serious mental health or substance use disorder who also have other social criteria needs. Children and youth involved in child welfare services, as has been mentioned in presentations and in the chat, and then those transitioning or who have transitioned from incarceration within the last 12 months. And within each of these populations, there are kind of a list of different conditions people must qualify for. And we can answer more questions about that if you have them. So what are the ECM core services? So once someone is deemed eligible and connected with ECM, services that are provided are included on that left side of the slide, and based on what the member needs. So most importantly, there might be outreach for coordination, conducting a comprehensive assessment, and developing a care management plan. So recognizing that people are multifactorial human beings, coordinating care across those systems, and then supporting connections to other community services and supports. We do have a number of ECM birth equity providers already who are experienced in working with pregnant and postpartum individuals dealing with intimate partner violence. They have been contracted with a number of plans throughout the state. And as mentioned previously, this is a place that we are continually talking with plans about to encourage improved contracting. Additionally, I want to highlight that, for any of the providers or healthcare adjacent individuals, lots of times we make referrals and we don't really know what happens. As of July 1st of this year, we have a closed loop referral policy, which means that plans are required to close the loop on all referrals that are made, including ECM and community supports referrals, and let the person who referred them, so potentially you, know the status of the referral and whether members got connected to those services. Our second highlighted benefit that I wanted to talk about are as a part of our community support system. So Medi-Cal now covers 14 community supports, which are various services that can help address members' health-related needs, help them lead healthier lives, and avoid higher, costlier levels of care. In relationship to IPV, an important support to highlight is transitional rent. Under the transitional rent program, MCPs will cover up to 6 months of rental assistance for people who are experienced or at risk of homelessness and meet certain other criteria. Given the circumstances of those experiencing intimate partner violence, individuals may be at risk of homelessness or are fleeing unsafe situations. The goal here is to provide a time-limited opportunity to help members establish a bridge to long-term housing supports and permanent housing. This is especially important given what we know about shelters' limitations in their offerings for this population, as Erica discussed previously. We also know that individuals experiencing housing instability may lose connection or forego, just based on priorities, connection with needed healthcare services and other social services. So this benefit currently is optional right now, but as of January 1st, 2026, will be mandatory for those with behavioral health qualifying conditions. And then just to note that as soon as someone qualifies for transitional rent, they're automatically eligible and authorized for ECM services that I talked about. So we'll be able to have additional supports in terms of individuals doing some care coordination. We won't go into the specifics for how people qualify for transitional rent, but I do want to emphasize that it will be implemented over time for a variety of populations. So as of January 1st, only those with behavioral health qualifying conditions will be eligible, with pregnant and postpartum populations of focus voluntary and will be cycled in as mandatory to be covered over the next couple years. However, if you do have pregnant people who have behavioral health issues, making sure they're referred appropriately will be important for your patients to get opportunities for the transitional rent service. And then finally, I wanted to highlight our transitional care services policies, which all members are entitled to when transferring from one setting of care to another. So this might be discharge from a hospital after hospital admission or discharge after the delivery of a baby for those individuals who are pregnant or postpartum. Of note, this also includes individuals who have a miscarriage or who have abortions as an end to a pregnancy, which can occur. So the TCS policy is a new policy for pregnant and postpartum members that is under development and is going to be released at the beginning of 2026. And so essentially all birthing people are required to be linked to a set of certain defined services, including social services, behavioral health services, and physical services based on what members need after a risk assessment. And so this is just another touch point for pregnant and postpartum members to be referred to the appropriate services that they need. And then kind of some additional eligible benefits include community health workers, doulas, peer supports, and then dyadic services that are all covered under Medi-Cal plans, but we're just not going to talk about them in depth today. And then finally, I just wanted to highlight an opportunity that emphasizes how managed Medi-Cal plans are taking action in this area. Next slide. So funded by the Blue Shield Foundation of California and the Population Health Learning Center, and in partnership with Futures Without Violence, there are 6 managed care plans throughout California that are participating in a community of practice or a learning collaborative that aims to improve services to address to address and prevent intimate partner violence. It's not specific to the pregnancy setting and includes all individuals affected by intimate partner violence, but these managed care plans are receiving supports to develop and adapt IPV education materials for providers, implement universal education across primary care providers to educate members about connections between intimate partner violence and health, and build connections with local IPV advocates and service organizations, which is where some of those ECM services could be linked. At the end of the year, after developing strategic plans, these 6 plans will be able to launch their action plan throughout their network of organizations. And so while this is a pilot period, if you are associated with a managed Medi-Cal plan and have interest in participating in the future, please drop me a line in the chat. So what can you do? For all of the people on this call, based on everything we've heard, please ensure you're appropriately screening for IPV or having those conversations. As mentioned, referring those who screen positive to appropriate referrals as covered by Medi-Cal. And we know that there's tons of community organizations here, or of community organizations who can get enrolled as ECM or community supports providers to help these populations. We know that a lot of community organizations struggle with funding, and so being enrolled as a Medi-Cal ECM provider is just another way to help support that funding stream. And then for anyone who is able to work with their managed care plan through Medi-Cal to contract with these CBOs as ECM providers would be helpful and increase that referral support network. And so thank you to everyone. And I am going to welcome back all of the speakers and introduce Christina Oldini, who is the Associate Director at CMQCC.
Anna, Dr. Coutinho, thank you very much. Good morning, everybody. I'm Christina Oldini. I'm the Associate Director here at CMQCC. And first of all, before we continue this discussion with our panel, I welcome everybody to come on camera and unmute yourself. I want to thank you all for attending today for this incredibly valuable conversation. I also want to recognize Stanford Medicine Children's Health and the Maternal Health Innovation Project out of the state of California for their funding. That project is funded by HRSA under HHS, and we are grateful to all of you. Want to recognize our interpreters. And Daniela and Amanda have been incredible. We are very grateful to work with you, and we know that that is such an incredibly valuable service. Okay, everybody, we've got much to discuss. So I'm going to kick it off on that note of interpretation, and especially those that are in touch with persons who experience this violence. Language services. This is important not only for all care we provide. I am a nurse also. Please speak to the importance of utilizing appropriate interpretation translation during care. And I'm wondering if you have found when it is not adequate, their caregivers' biases set in, and wondering if the person is not interested. Why are they not engaging? So that's one note I'd love to talk about. The second part is behind the idea, so two parts. Second part, regarding kind of an interrogation type thing, potentially utilizing translators. So, and so where I'm going with that is really the partnership, if there's any chance with the interpreters who are providing the translation, to really partake in relationship building with them so they understand, right? Training for the interpreters. So Chyna, Dr. Hill, I'm going to kick this off with you if you're okay. I'd love you to offer anything. Thank you.
For sure, and thank you for having me and directing that question. I think that language services is pretty important for use in this particular area. And I will say, without those services is literally the difference between someone coming once and you never seeing them again, right? That could be your only shot to get in front of them, to have a conversation with them, to see what supports that they need. So having those services, are really important. And if you don't have that language capacity, it's really important to be upfront and say, hey, we don't have that capacity in-house, but let me do a warm handoff to someone who does. I think that is so critical because it really makes a difference in whether that person not only comes back to your particular organization, but it goes to any organization moving forward, right? You want to absolutely make sure that you have someone who is available for them. And then when it comes to intimate partner violence and the use of the cues model or how we tackle IPV, I think this training is for everyone, not just for doulas and nurses and lactation consultants, but for interpreters as well, because I think that language piece is so critical, and using trauma-informed language and what that looks like, especially through an interpreter, because it can differ. And making sure that things aren't lost in translation. I think those services are so critical to IPV work.
Would anyone else like to expand on that?
Oh, sorry. Is it okay if I go, or
Please,
did
Maya,
you want
go,
to? Are
go.
you sure? Okay.
Yeah.
Because I know that other folks have so many valuable perspectives. I don't want to take up too much time. I wanted to just share this idea, and I'm happy to share these if they're helpful. This idea of language justice. And so we often hear about language access, and in my mind, language access in healthcare systems is like we have an interpreter somewhere in this building, but no one knows where. Language justice is this systems level approach that shifts the responsibility from the patients needing to advocate for interpreters to the healthcare system to seamlessly interweave language systems or language services into the system. And I actually, my colleagues and I have created some checklists that people can use. Now they're just a checklist. It is not like there's so much more that is needed, but if those are helpful for anybody, I'm happy to offer them. I want to just share two other thoughts. The first is often, so when we use the word interpreter, we mean spoken and signed communication. When we use the word translator, we mean written communication. So that's just when I use those words, that's how I'm referring. And one of the things that like has been remarkable to me, I've been practicing for about a decade, is just the rapid shift to written communication, right? Like you can message your doctor, you can do telemedicine, and there are so many disparities in people being able to access patient portals or telemedicine services if you use a language other than English. So I really implore healthcare systems as we continue to optimize and really make sure we're offering professional interpreters to everybody and not using ad hoc interpreters, not using family members. I still can't tell you the number of times my patients who use languages other than English, their parents have said that they asked, like someone asked them their 12-year-old child to interpret. So not doing that, to also really make sure we're thinking about written communication. As for IPV, there's so many challenges interacting with healthcare. We want to make sure that our survivors can use the patient portal if that's what's safe for them, can do a telemedicine visit if that's what's safe for them. And if those services aren't available in other languages, that's basically cutting off those services. And we know that when we don't innovate thinking about health equity, we're not actually innovating. So that is another thing. And then the last thing I wanted to share is this idea of trauma-informed interpretation. So I've learned a lot about trauma-informed interpretation from Caminar Latino and the Asian Pacific Institute Gender-Based Violence, or for Gender-Based Violence, which is in San Francisco. And they have a lot of great trainings on that. But what I'll share is just as a reminder, like interpreters may be experiencing intimate partner violence. And so sometimes it can be really jarring for an interpreter to like jump into those conversations. So if we can prep interpreters and just make sure we're being thoughtful about their experiences before we jump into those conversations, I think that can be really helpful. So sorry, that was a lot, but I'm happy to share those checklists and just really this language justice. I have this like dream that like that we really can have it so the patients don't have to advocate for their own language services when they're sick and they're vulnerable. Like they don't have to say, I need an interpreter. We ask everybody what their language identity is at the beginning, what their language preference is, and then those who need interpreters get an interpreter. There's no stigma attached to it, and they get those services. So just something for us to all be working towards.
Maya, number one, yes, we would love those resources. We will include them in a very comprehensive email out to all the attendees. So we will be reaching out to all of you as faculty and see what you'd like to include in that email, number one. Number two, incredible. Please don't ever apologize for sharing incredible information. And I want to share, I was very fortunate to lead a diabetes and pregnancy program in San Francisco for many years. And we were so fortunate to have integrated interpretation by certified interpreter. It's just incredible. And I know, as working in a healthcare system for a long time, social work and translators are those that are often cut first. So we think of them as, yeah, it'd be great to have, but if we don't, it really does need to take that more justice focus. And so thank you for mentioning that. I want to move into mental health challenges and how difficult this is, especially if partners, significant others in the relationship have mental health challenges. And I want to focus for a minute on the children. So resources, counseling, can any of you please speak to the children that are witness to this don't know what they're witnessing. And what kind of care should we be focusing on for the children and siblings? Maya, are you able to speak to that?
Sure. And I mean, I'd really love to hear like what Erica and Chyna and Anastasia say as well, because I'm not located in the Bay Area. I mean, I think as a pediatrician, you know, it really does impact children, but I feel like the way that such an important way to support children is to support their parent and their caregiver. It's very hard for a child to be well when their parent or caregiver isn't thriving and well. So like what I love about being a pediatrician is I do feel like we try to support the family. I think it's really important to connect children and families with people that have expertise in this space, which is, you know, and that connecting them with folks that have like, you know, PCIT, like folks that can really support the family unit and the survivor as well. I also think it's so important to make sure that like IPV survivors do so much to protect their children. And I think sometimes all they hear is like, you're not a good parent. Look what you're doing. Like, and I know none of us would say that, but that's what they hear sometimes. So just like wrapping the survivor up in like love and affirmation as we're connecting them to resources, I think that's really important as well. But I'll start with that, but I'd love to hear what other people think and some of the local resources.
Erica, would you like to speak to that, please?
Yeah, I would say the most important thing is enhancing those protective factors. And the primary protective factor is having a safe adult in that child's life. That's one of the main ones, is having that parent that really cares, that can be there for that child, right? That can be that safety. And then addressing whatever comes in. But I think the most essential, what we found out in terms of the work that we do, is ensuring that the child has a safe parent or a safe adult that they can go to. And then addressing whatever else, like, because it could lead to eating disorders, right? That instability, like having to go to a shelter can be traumatic in itself. And so our families, when they go into a shelter, they have access to therapy services, not just for them, but for their children. We also have children's advocates that work with the mom to find out what are other resources that they might need and connecting them with them, because you don't know how it's going to impact the child. It might be behavioral changes. It might be eating disorders. It might be unhealthy sleeping patterns. So it just all depends. And it's sort of like being able to provide those wraparound services to address whatever it is, working with the school. So it has to be like that, you know, that whole community. A community impacts a child. So being able to work with different sectors to address those one child's needs.
Erica, I'm going to continue with you for a moment here. IPV in the teen population and adolescents. Can you speak to whether, I don't know where you want to go with this, whether it's resources in the Bay Area, if you want to talk about experiences you've had, but anything to speak and address really the population during those years that are experiencing IPV themselves?
Yeah, it can be very challenging working with this population because not only are they trying to find out their identity, right? During the teen years is when your identity develops. And so you may have, and working with teens, you may already work with teens that have either been victimized or been abusive, have abusive characteristics. And then there's those that are wanting to play a role or like are interested in this topic, right? So you have those leaders, you have those that have been victimized, and then you have those that are the ones that are causing the abuse. And so really the way we've done it, we have a group called the Teen Talk. And so we have different teens coming in. And this is a partnership that we have with Bill Wilson Center. So Bill Wilson is an organization that provides services for young adults and teens, homeless teens. And so we were going into their shelter to provide Teen Talk, which is just a space for kids to talk, have a conversation. And we've incorporated conversations around promoting healthy relationships. And that has been the best avenue, is really promoting what's healthy and not sort of focusing on like, this is bad, this is unhealthy, but focusing on what's healthy. We did activities around self-care, how to make your own scrubs, and even the boys were interested in that. So it's really creating that safe space to have those conversations. And so we've worked with different schools as well, particularly their social media class, where they themselves can create content, and provided opportunities for them to get involved and be an upstander. So that's really been our focus, promoting those healthy relationships, being an upstander. How do you intervene when you see a friend that's experiencing this? Because that empowers the youth. And of course, there's been those times where we have provided services for youth, and it can get a little bit tricky because of the parental involvement, depending on what it is that they're seeking. And so oftentimes we've been able to keep it confidential, where we've had teens receive ongoing support, where they're receiving case management, and we're helping them navigate the abuse, whether it's happening in school, whether it's happening outside of school, and allowing them to lead. We went and did a presentation, and I actually had a teen that came up to me and said, I wanted to thank you because I've been receiving I've been working with my advocate for 2 years, and that's helped me a lot, and I'm about to graduate. So it's those stories. I think it's following that model of allowing the individual to lead, right? And really building up on their strengths is important, and particularly at that young age.
Thank you, Erica. I'm so sorry. We only have 10 minutes left, so I'm gonna keep going here. This is really something. So Chyna, Ana, when the victim is not female, right? When the victim may be male or other identity. Chyna, can you speak to this and anything you can offer? How can we support other populations that are experiencing this?
Yeah, so this is a very real question, and thank you for asking it. I think when it comes to supporting victims who don't identify as female, the support has to be really intentional, and we have to both address the stigma of why folks don't come forward and also invisibility, right? So, in general, we know that IPV is about that power, that control, and that harm. But when it comes to male victims of IPV, they may minimize or hide the abuse because of the stigma associated with being seen as weak or not being believed, right? And they may face issues of service providers lacking the services to provide for male victims of IPV. And so it's really important when you're working with folks who are in this particular situation that you are making sure you're using gender neutral phrasing, like, hey, do you ever feel unsafe or controlled in your relationship? Because we know that men are more likely to underreport. Has anyone close to you ever hurt you, threatened you, or humiliated you, right? Because we know, again, men are more likely to underreport. And how does your partner respond when you disagree or assert yourself, right? I think it's really important that we have to recognize as providers the barriers to disclosure that can be unique for folks who identify as male, like the cultural and societal norms, fear of being perceived as the aggressor, right? Especially among men of color. Limited services that accommodate male or even non-binary survivors are things that we have to pay attention to. So I think it's really important for us as providers to really name that IPV impacts all people, right? It's not just limited to folks who identify as female. And then provide tailored resources. There are programs that really support male and non-female survivors of intimate partner violence, and it's important that we let folks know that those exist. So, as a provider, as I would say, it's really important to train our teams and the folks around us to provide this level of support without minimizing or overcorrecting, right?
Thank you, Chyna. Thank you. This question, we're getting close, but I'd like to ask our two physicians. We're fortunate today to have a pediatrician and a family medicine provider. Can you speak to a question came in about a group of providers, specifically physicians in the emergency room. And their comment was that ED doctors don't take the time to go through this level of support. And whether it's they don't take the time or they view it as they don't have the time, the point is it's not there. What do you recommend to help train physicians better?
I'm happy to take it. Whoever the family medicine physician, sorry, because
Dr. Coutinho, Dr.
Perfect.
Coutinho.
Do you want to go first then, Dr. Coutinho? No, go ahead. That's fine.
I know.
No, this is your area of expertise.
Okay. But anybody feel free to add in. I think it's really hard, and I just want to like level set the fact that, I mean, I'm not an emergency room provider. I'm a primary care pediatrician, but like we also we're asked to see patients really quickly, and I think that the goal always has to be systems level. Like, I think it's not really fair to put this all on individual providers. And by provider, I mean like nurse, doctor, nurse practitioner, like any provider.
Yeah.
I will say that there has been some great work in the pediatric emergency room that one of my colleagues and friends has worked on to implement cues. And actually, interestingly, compared with even primary care, the pediatric emergency room setting, there's a lot of pediatric emergency rooms that have implemented cues. And so I'm happy, whoever the person was that asked that question, I'm happy to connect you with those folks. I think actually cues can sometimes work better when it's not provider delivered, but if there's like a written thing that people can read. I think the implementation of anything provider delivered is very difficult. It's very, very hard. I will say, I mean, I've been doing research in this and like advocacy in this for years, and sometimes I forget like during a visit to do cues, right? I mean, so like I really don't begrudge anybody who forgets this. I think having it built into systems is helpful. I think the other thing that is really helpful is having co-located advocates. So like when I've worked in healthcare systems that have co-located advocates, it's so much easier for me because as soon as somebody discloses, like not in any kind of rushed way, but I can say, thank you so much for sharing your story. You know, we have an expert here who really helps, folks that are going through this. Like, would you like to speak with them? And I think like the way that we rely on teams, like we have to do the same thing. So that can be really helpful. And then I'm happy to share other like implementation strategies and other resources and things like that. If you want to email me. But I will say, I think the emergency room is a really important place to do this work. Oftentimes it's a place where people, especially who don't have access to primary care, where they come to get their health care. So it's a really important space. And there are some really great models for how to do it. It can be really difficult, but I also think there are strategies that we can talk about more. So.
Excellent. Thank you so much. We have 4 minutes left, and we're going to do this. I'm going to do a very quick round robin, and what I want you to do is speak to survivors that perhaps are staying because they have to. They feel they have to currently. So what are those things, Erica, Chyna, when you're working with these folks, Maya, what do you want to say to them? What do you feel like you want to get across in terms of immediate safety? And so I'm going to end it there. You know what I'm getting at. And Erica, I'm going to start with you.
Reach out. There are service providers such as ourselves that are here for survivors. Most service providers, the services are confidential. We do not work with law enforcement. We do not work with mandated, or we don't do mandated reporting. So oftentimes the concern is about being seen, being heard, and being believed. We believe you. There are people that care. There are services for you that can help you navigate that difficult time. And it's really reaching out there. That's why hotlines exist. Even if you call and you change your name, even just to find out information, do that. Start there if the fear is so big. But take that step, because the sooner you take that step, the sooner you will start to address and have life-changing opportunities that can lead you to a better healing process.
Thank you, Erica. Chyna?
So just echoing that, I would just say that you deserve safety, you deserve peace, and love that doesn't hurt. And healing, moving through intimate partner violence really takes time. And it's okay to feel that this process is slow, that it's complicated, or even uncertain. But I would want you to know that you're doing the absolute best that you can in a situation that no one should have to face. There is help available, and it's absolutely your right to reach for it. So whether you choose to leave, whether you choose to stay, plan, or just take one more step towards healing, you are worthy of care and respect at every stage. And you don't need to be perfect to be believed. We believe you, and we're here.
Christina, you're muted. We can't hear you anymore.
No.
No.
And Patricia?
There you go. You're back on.
Thank you. So the Mid-Coastal Perinatal Outreach Program is stronger because of our speakers, because of our faculty. They are our partners. And we thank each and every one of them for their care, their heart, their subject matter expertise, and their willingness to participate today. Thank you to, again, Amanda and Daniela for offering the translation. To the team, Amy, Patricia, Marcy, everyone on the back end, our comms, Meredith, Serena. None of this would have been possible without any of you. Thank you. Please stay tuned. You will receive an email talking about the slides and where the recording will be available. Also, be prepared to receive an email that will have much information in it. Thank you to all of you. This is our CE information, our continuing education. Please know you must complete the evaluation. The next slide is going to tell you to keep in touch with us at MCCPOP. You'll receive the email, so you'll know that. And if you could put up that last slide, Amy, know that your quality collaborative, the last slide, the quality collaborative in California, CMTCC and CPTCC together. I'm sorry, I guess we don't have that slide. You will receive that information. Please stay in touch with both of those. We are honored to have all of you today. Please stay well, care for yourselves. Thank you.